Committee will come to order. Without objections, all members will have 5 days to submit statements, extraneous material, and questions for the record, subject to the length limitation in the rules. This morning, we'll take a hard look at something the full committee hasn't held a hearing on in more than a decade: global women's health. I want to welcome our witnesses to the Foreign Affairs Committee. It's always nice to have colleagues come and talk to us, because we know that colleagues have more expertise than anybody else. So I want to welcome them. I want to welcome members of the public and the press as well. And today we'll hear from two panels. First, from two of our distinguished colleagues. Then a panel from, let me just shut this off here. Sorry.
It's your daughter, looks like.
My wife, actually. Yeah.
That's the boss. You should answer it.
So we'll hear from two panels today. First, from two of our distinguished colleagues, then from a panel of experts.
That's her again.
Let me just get this off. Sorry about this. So we're grateful to you for your time. I now recognize myself for an opening statement. This is one of those topics where I think it's helpful to take a step back and look at the big picture so we can understand why this issue, global women's health, should be a foreign policy priority. We know that when women are able to live fuller, more productive lives, when they have access to education and economic opportunity, when they can be full participants in their communities and societies, it acts like a rising tide. Entire countries become more stable, more open, and more prosperous. When women have a seat at the table, we see better results in resolving conflicts and rebuilding after crises. A whole host of foreign policy challenges are more easily overcome when women are involved, when women can live their lives to their full potential. And when we dig down, it's clear that unleashing that potential is directly tied to women's access to health care, particularly family planning. Study after study after study has told us improving access to contraception improves women's economic well-being. Women who can plan having children on their own timetables are more likely to get an education, to raise their standards of living, to climb out of poverty. And this is where so many women hit a roadblock. Only about half of the women in developing countries receive the minimum recommended prenatal care, and that number drops in sub-Saharan Africa. Every year, more than 300,000 women die from complications during childbirth. That's a shocking statistic, an estimated third of which could be prevented if the women had access to contraception and greater choice over whether or not to become pregnant. It's a human tragedy, and it wipes away all those positive effects that ripple out when women are able to make choices for themselves and can get the health care they need. American assistance has traditionally played a major role in helping women and girls get better access to health care. In fact, global health makes up the largest single share of civilian aid overseas. Over the years, American-backed assistance for family planning, maternal and child health and nutrition, and PEPFAR have made a real difference around the world. Unfortunately, the Trump administration has threatened to undo a lot of that progress. It has tried again and again to slash America's investment in family planning and reproductive health. The administration has tried to hobble the UN Population Fund, arguably the most important organization in the world for helping women get the care they need. And let me focus on this for a minute. UNFPA purchases and distributes contraceptives, facilitates safe childbirth, promotes maternal and reproductive health, works to end female genital mutilation, and assists victims of gender-based violence. In 150 countries around the world, which includes 100 where USAID doesn't operate, in war-torn areas and in the middle of humanitarian disasters, UNFPA is a lifeline for the world's most vulnerable women and girls. These are people with nowhere else to turn. So what has the Trump administration done with this? The answer, unfortunately, is eliminated American support for it. And of course, the administration has reinstated and expanded the global gag rule. This is a policy that does, I think, the opposite of what its supporters say. I'll leave it to our witnesses to shine a light on just how much damage it does, how it undermines everything we know can be gained when women get a fair shot. This policy should be repealed permanently, and that's what the Global HER Act, HER Act, would do. And one of our witnesses this morning is that bill's author, my friend, my good friend, and neighbor from New York, whose district borders mine for 30 years, the chairwoman of the Committee on Appropriations, the first woman to chair that committee, Mrs. Lowy. We'll also hear from another colleague, a member of the Energy and Commerce Subcommittee on Health, the distinguished gentlewoman from Washington, Ms. McMorris Rogers. So, two great witnesses. I look forward to opening statements from our colleagues, pending which I'll yield to my friend from Texas, our ranking member, for any opening comments he may have.
Thank you, Mr. Chairman, and for holding this important hearing. And if I were you, I'd answer my wife's phone call. I also want to thank my colleagues and friends for being here today. Kathy and I came into Congress together, and Nita has been a dear friend and the real leader in the Congress. The United States is the largest donor to global health programs by far. We have a long history of supporting efforts to improve health outcomes of people all over the world, from providing life-saving treatment to building the capacity of health systems. The U.S. has also been a global leader in founding and funding programs that support women and girls around the world. As a father of 4 young women, I recognize the importance of empowering women and girls to succeed, and that starts with access to health resources and education. Through our contributions to the multinational programs like the Global Health Fund that the chairman and I got fully funded when some tried to cut it, the United States has been a global leader in the fight against HIV/AIDS, malaria, tuberculosis, and other diseases that disproportionately impact the world's most vulnerable populations. This is largely thanks to the visionary leadership, I believe, of President George W. Bush. Bilateral global health programs, as well as broader initiatives like PEPFAR and the President's Malaria Initiative, have saved tens of millions of lives around the world. Last year, I had the honor to meet the President of Botswana, and he told me that thanks to the PEPFAR program, that the United States saved, in his words, a generation. What's going on there? It's very odd. Anyway, he told me that PEPFAR saved, in his words, quote, a generation of Botswanans from extinction. From extinction. It's very profound. We can and should be proud of America's continued leadership on these issues. And that is why I was proud to sponsor House Resolution 517, along with Chairman Engel, which reaffirmed United States support for the Global Fund. We were successful in these efforts. The year-end spending package included $1.56 billion for the Global Fund and substantial increases in assistance for maternal and child health and nutrition, among other programs. In September of last year, the Bush Foundation and Ambassador Birx announced the Go Further partnership to end AIDS and cervical cancer had reached over 500,000 women living with HIV to provide cervical cancer screenings. This is a fantastic example of how innovative public-private partnerships can build on successful U.S. government programs to reach even more women and girls with expanded services. Like the Go Further partnership, there's unique opportunity to build on the success of the U.S. global health programs and address other health challenges like childhood cancer. Last week, along with the chairman, the House unanimously passed the Global Hope Act. And I do want to thank Chairman Engel for his support of this efforts. This legislation supports efforts to reduce childhood cancer rates in developing countries by facilitating similar public-private partnerships between the federal government, the private sector, research institutions, and non-governmental organizations. The mortality rate for children diagnosed with cancer in developing nations is 80%. Tragically, this matches the survival rate in the United States. I don't think it depends where you're born to determine whether you should receive this critical care. And by working together to address the resource gaps that exist and leverage private sector expertise on the unique challenges that this horrific disease poses, I think we can dramatically reduce childhood cancer mortality. We must ensure that every child, no matter where they are born, has access to the care and treatment that they need. And so I look forward to working with my colleagues in the Senate to see that the Global Hope Act is signed into law. We saved over 20 million people in Africa thanks to the PEPFAR HIV program. The Global Hope Act has the same opportunity, I think, to save millions of children's lives. And I can't think of anything more profound that we can do in the Congress and pass a bill that turns into saving millions of lives. And with that, Mr. Chairman, I yield back.
Thank you, Mr. McCall. I'll now recognize our witnesses for 5 minutes each. Chairwoman Lowy, we'll start with you. Thank you for coming this morning. It's great seeing you.
It is a pleasure to be here with you, Chairman Engel, and Ranking Member McCall, and so many good friends on this committee. Thank you for allowing me to testify during this important hearing on the unique challenges women face in global health. As my fellow witnesses will outline, the number of obstacles that women around the world face in their pursuit of health services is almost too many to list. But instead of tackling these obstacles, President Trump simply created more barriers when he quickly imposed the dangerous, ill-informed Mexico City policy, also known as the Global Gag Rule, in 2017. During previous Republican administration, this policy cut off U.S. family planning funds to any foreign non-governmental organization that provided services for, information about, or referrals for abortion, or advocated for abortion access, even where it was legal, and even with its own private funds. But this administration radically expanded the policy to apply these restrictions to all global health funding, affecting approximately $8.8 billion in U.S. assistance to programs tackling HIV and AIDS, family planning, reproductive health, tuberculosis, malaria, maternal and child health, water, sanitation and hygiene, and more. And just this year, the administration announced it was expanding the policy once again, changing the definition of providing financial support contained within the executive order's standard provisions. When the Global Gag Rule was simply applied to family planning programs, we saw disastrous impacts, not just for women, but also for their families and their communities. Fewer women were able to access family planning services, resulting in more unintended pregnancies and unsafe abortions. Some of our most trusted implementation partners overseas were forced to choose between receiving U.S. funding or providing comprehensive health care, often leaving thousands of women without access to the most experienced providers. This administration's unprecedented expansions which were implemented with no analysis of the potential impacts, now risk multiplying the damage. We have heard of numerous HIV and AIDS, maternal and child health, nutrition, and WASH programs that were forced to cut services or close because of this policy. Meanwhile, implementers have tied themselves in knots trying to comply, or even worse, just walked away from partnering with the U.S. altogether. And mass confusion about the policy has led to a chilling effect, causing organizations to unnecessarily change or eliminate vital health services. Simply put, this policy hurts the very people we're trying to help. We should be building on our global health successes, not reversing the gains we've made. That is why I introduced H.R. 1055, the Global Health Empowerment and Rights HER Act, which would permanently end this devastating policy once and for all. This bill, which I am hopeful the committee will consider in the near future, sends an important message to international global health partners and has a record number of co-sponsors and support from a long list of diverse organizations that know the global gag rule is bad for global health, bad for human rights, bad for gender equality. Passing this legislation would restore our country's role as an international leader and ensure that women, men, and children around the world are able to access the health care they so desperately need. Thank you.
Thank you, Chairwoman Lowy. Ms. McMorris-Rogers.
Thank you, Mr. Chairman, Ranking Member Michael McCall, to all the members, but especially to the Chairman and the Ranking Member. I want to just applaud your leadership. Both of you are extraordinary leaders and appreciate your leadership on so many issues before this committee. Since America's founding, we've cherished every person's inalienable rights, human rights, to life, liberty, and the pursuit of happiness. It's on us, all of us, to uphold these values and make sure they are reflected at home and abroad. The Trump administration has provided historic leadership on this front. In January of 2017, President Trump implemented the Protecting Life in Global Health Assistance Policy, which has expanded on the Mexico City policy. This affirms the dignity of the unborn life in foreign aid funding. It requires foreign, non-governmental organizations to agree not to perform or promote abortion as a method of family planning overseas. Organizations that provide and promote abortions abroad should under no circumstances be funded by American taxpayers. In fact, according to the latest Marxist poll, 6 out of 10 Americans oppose using tax dollars to pay for abortion. More than 3 in 4 Americans oppose using tax dollars to support abortions in other countries. The terms of PLGHR are clear and in line with overwhelming public opinion. NGOs can receive Global Health Assistance Awards if they agree to abide by PLGHR policy. PLGHA does not reduce the amount of global health assistance that we make available or prohibit any group from receiving U.S. assistance. And I want to repeat that. This policy does not reduce the amount of global health assistance, nor does it cut funding from any organizations. The only organizations to not receive funding under PLGHA are those who have chosen not to accept the policy restrictions that come with U.S. assistance. It means we are using resources for health care and life-saving care of both women and children. It provides essential health care, nutritional aid, and humanitarian assistance to people in need at every stage of their lives. To win the future, America should be leading to affirm the dignity and value of both patients, mothers and children. That's why here at home, I've led on solutions to reduce maternal and infant mortality. Again, as warriors for human dignity and human value, I applaud this administration's historic leadership on policies like PLGHA, from combating human trafficking to promoting freedom and opportunity, and also improving health care for women and our most vulnerable. America must lead and continue to lead and encourage the rest of the world to follow our leadership. I thank you for the opportunity to be with you today.
Well, thank you both. I always say that words that come out of our colleagues' mouths are always the wisest words. So I want to thank both of you, who I know care very much about this issue. And we'll now recess briefly to reset the witness table and seat our second panel. Okay, we'll continue with our second panel, whom I'll introduce. Firstly, Dr. Jennifer Cates is Senior Vice President and Director of Global Health and HIV Policy at the Kaiser Family Foundation. She oversees the foundation's policy analysis and research focused on the U.S. government's role in global health and on the global health and domestic HIV epidemics. Welcome. Sheba Crocker is CARE USA's Vice President for Humanitarian Policy and Practice and is also currently a Centennial Fellow at Georgetown University's School of Foreign Service. She previously served as Assistant Secretary of State for International Organizational Affairs, Director in the Office of Policy Planning, and Chief of Staff to the Deputy Secretary of State. Welcome. Moses Mulumba is a lawyer with special interest in international human rights, global health, and sexual reproductive health and rights. He is the founder and current executive director of the Center for Health, Human Rights, and Development based in Uganda. Lisa Boss is the Director of Government Relations at World Vision US. She leads World Vision's advocacy and education efforts with Congress and the administration. She previously served for nearly 9 years as a staff member here in the House, including as policy director for the Republican Study Committee. So welcome to all of you. Without objection, your written testimony will be made part of the hearing record, and I'll recognize each of you for 5 minutes to summarize your statement. We'll start with Dr. Cates. Welcome.
Thank you. Good morning, Chairman Engel, Ranking Member McCall, members of the committee, and guests. I'm Dr. Jen Cates, Senior Vice President and Director of Global Health and HIV Policy at KFF, the Kaiser Family Foundation, a nonprofit, nonpartisan organization that conducts independent health policy analysis. Thank you so much for inviting me to testify at this important and timely hearing. I will briefly summarize my written testimony and focus my remarks on 3 areas: an overview of the U.S. government's role in addressing the health of women in low and middle income countries, what we know about impact to date, and current and future challenges and opportunities. U.S. efforts to address the health of women in low and middle income countries began decades ago, and since then the U.S. has been, and today remains, the largest donor in this area globally. Major efforts include USAID's maternal and child health, nutrition, and family planning and reproductive health programs, as well as related efforts, particularly PEPFAR and its DREAMS initiative. Studies have shown that improving the health of women has significant spillover effects on the health and economic well-being of their families, communities, and societies. The U.S. footprint is large, spanning more than 50 low and middle-income countries, mostly in sub-Saharan Africa, and reaching tens of millions of women and girls. In fiscal year 2020, the U.S. committed $1.4 billion to maternal and child health, including nutrition, and $608 million to family planning and reproductive health. And PEPFAR estimates that it will spend nearly $2 billion on efforts to support women and girls. Collectively, these programs support a range of services that address women's health, including the provision of contraceptives, family planning and counseling, protecting the health of pregnant women during and after childbirth, addressing child marriage and gender-based violence, and increasing access to HIV prevention and treatment. It's important to note that the U.S. by law prohibits the direct use of U.S. foreign assistance for abortion as method of family planning. U.S. support has contributed to significant impact. USAID reports that its investments have helped to reduce the chances a woman will die in childbirth by more than half in USAID priority countries. In addition, contraceptive prevalence has increased significantly in these countries, and new HIV infections have fallen among women in almost all PEPFAR countries. Despite these successes, numerous challenges remain and progress has slowed. Globally, nearly 300,000 women still die during pregnancy and in childbirth, and millions more experience illness and severe adverse consequences each year, largely from preventable or treatable causes. More than 200 million women would prefer to avoid or delay childbearing, but are not using a modern method of contraception. And 1 in 7 girls faces early or forced marriage. Further, women are at disproportionate risk of HIV, the leading cause of death globally for women aged 15 to 49. Looking ahead, the population of adolescent girls is expected to grow significantly over the next few decades, particularly in sub-Saharan Africa, yet the global community is not prepared to meet their health needs. Among key challenges facing the future of the U.S. response are, first, while the U.S. remains the largest donor to women's health in the world, in recent years, funding has been mostly flat and cuts have been proposed. Second, although domestic resources have increased in many countries, they have not grown fast enough or with enough magnitude to replace external aid, and many countries with significant need are particularly vulnerable to any reduction in U.S. support. Third, most global health programs, including those that specifically seek to reach women, focus on pregnant women or children under 5, leaving a gap in available services and programming for adolescent girls and young women. Finally, legal and policy requirements, including more than 20 specifically related to family planning and reproductive health, more than any other area of global health, can present barriers. For example, the reinstated and expanded Mexico City policy, now known as Protecting Life and Global Health Assistance, for the first time applies to nearly all bilateral U.S. global health assistance, including PEPFAR, and a much greater number of foreign NGOs than ever before. The policy has presented implementation challenges and led to service gaps in some communities. A recent empirical analysis found that when in place in the past, abortion rates and pregnancies rose, and the use of modern contraception fell in the countries most exposed to the policy. Most of these challenges are concentrated in countries reached by the U.S., suggesting additional opportunities for impact, including exploring the use of incentives for domestic resource mobilization specific to women's health, better aligning and integrating U.S. efforts internally and with others, and pursuing multi-sectoral approaches, better meeting the needs of adolescent girls and young women, and reducing implementation and policy barriers. Together, these efforts can help ensure that the next generation of women and girls is healthier than ever before. I look forward to discussing these issues with you and answering any questions you have. Thank you.
Thank you, Dr. Cates. Ms. Crocker.
Chairman Engel, Ranking Member McCall, distinguished members of this committee.
If you can just pull the mic a little closer to you.
Sorry.
to you. No, it's okay.
Let me see if I can do that. Is this better?
I think so, yes.
Thank you for the opportunity to testify today as you examine the challenges facing women's health globally. These are critical issues, and I am thankful for the committee's attention to this matter. I have abbreviated my testimony, and I encourage the committee to consult my full written testimony for further recommendations, and I ask that they be entered into the record. My name is Sheba Crocker, and I am the Vice President of Humanitarian Policy and Practice at CARE USA. CARE was established nearly 75 years ago when a small group of Americans sent the first care packages overseas to survivors of World War II. Today, CARE works in 100 countries to address the root causes of suffering and to provide life-saving humanitarian assistance to people in need. CARE's work focuses on women and girls because our experience has taught us that we must help communities address gender inequalities in order to respond effectively to crises and to their underlying factors. Before I begin, I would like to take this opportunity to thank this committee and Congress for continued bipartisan commitment it has shown for development and humanitarian assistance. Helping those in need around the world is not and has never been a partisan issue, and CARE is grateful that the United States has such strong champions for continuing U.S. leadership on foreign assistance on both sides of the aisle. I would like to focus my remarks on 4 challenges to the health of women and girls in humanitarian settings: inadequate funding, lack of access of humanitarian workers to populations in need and of those populations to health care, social norms that expose women and girls to greater health risks, and issues that heavily affect or are unique to women, specifically gender-based violence and access to sexual and reproductive health services, which include contraceptives, quality obstetric care, pre- and postnatal services, and sexually transmitted infections prevention and treatment. First, although the number of people who require humanitarian assistance continues to rise, funding, particularly for emergency health care, lags. In 2019, the UN requested $2.4 billion to provide health care to vulnerable populations around the world, but global contributions totaled just 33% of that request, only some of which was dedicated to the unique needs of women and girls. Moreover, of the total humanitarian funding allocated between the years 2016 and 2018, gender-based violence prevention and response services received just 0.12%, or only 1/3 of the amount identified as needed for gender-based violence prevention and response. Second, access of humanitarian agencies to people in need and of women to health care is crucial. If we cannot reach people, we cannot help them. Even when humanitarian workers are on the ground, conflicts and natural disasters damage healthcare facilities and kill, displace, or disincentivize staff. For example, at least 60 health facilities in northwest Syria alone were damaged in airstrikes over just an 8-month period in 2019, affecting tens of thousands of people. In some societies, women are unable to attend clinics if no female staff are present or if male family members cannot accompany them, further compromising women's access to health care. Third, social norms can expose women and girls to greater health risks. Women and girls are often expected to nurse family members and are also typically the last to receive assistance. This means they are both at a higher risk of contracting communicable diseases and are less likely to receive the timely care they need. For example, 56% of confirmed and probable cases in the ongoing Ebola outbreak in the Eastern Democratic Republic of the Congo has been among women, and 28% among children under 18 years old. Just 11% of cases have been recorded among men over the age of 18. Fourth, there are some risks that particularly affect women and girls, namely gender-based violence and sexual and reproductive health. Available evidence suggests that multiple forms of gender-based violence remain pervasive in emergencies, including emotional, physical, and sexual assault, intimate partner violence, sexual exploitation and abuse, and child, early, and forced marriage. Gender-based violence can have sexual and reproductive health consequences for women, compounding the risks inherent in pregnancy and childbirth, which are dangerous even under the best of circumstances. However, For the millions of women who require humanitarian assistance and may lack access to health care, the risks are even higher. 60% of all preventable maternal deaths and 45% of all preventable newborn deaths occur in vulnerable states, many of which are affected by conflict and humanitarian emergencies. I would like to briefly share 3 priority areas for your action based on CARE's experience. First, the United States must prioritize funding for women's health services, including gender-based violence and prevention and response and family planning and reproductive health care, from the outset of a humanitarian response. Second, CARE strongly encourages strengthening policies that promote the health of women and girls in emergencies and addressing policies that restrict access. CARE supports the Safe from the Start Act, a bipartisan bill that strengthens the humanitarian system's capacity to prevent and respond to gender-based violence. Policies that restrict NGOs' ability to provide life-saving health services, such as the Mexico City policy, have been shown to reduce access to care and lead to poor health outcomes for women, and CARE calls for this policy's repeal. And CARE regrets the administration's decision to halt all funding to the United Nations Population Fund, despite consistent bipartisan support for that agency. CARE urges a speedy restoration of funds to UNFPA. And finally, to support the protection of women and girls and their access to humanitarian assistance, including health care assistance, the United States should continue its longstanding commitment to principled humanitarian action and be a global leader in promoting and ensuring compliance with international humanitarian law by all parties to conflict. The unique needs of women and girls must be treated with urgency during humanitarian response. CARE is committed to working with women, girls, men, and boys to elevate women and girls' potential so they can help build stronger and more resilient societies. Thank you very much, and I look forward to answering your questions.
Thank you very much, Ms. Crocker. Mr. Mulumba.
Thank you, Mr. Chairman, Ranking Member Mick McCall, and the members of the Foreign Affairs Committee. I appreciate the attention this committee is devoting to global women's health, and I welcome the opportunity to share some of the challenges vulnerable communities, notably women and girls.
Mr. Mulumba, let me ask you again to pull the microphone a little closer to your, yeah.
Thank you. I appreciate the attention this committee is devoting to global women's health, and I welcome the opportunity to share some of the challenges vulnerable communities, notably women and girls in Uganda, face in accessing health care. I summarize my opening statement, but ask that the full written testimony be entered onto the record. For close to 15 years, I have been working as a health and human rights advocate. In my current role as the executive director of my organization, my work focuses on ensuring social justice in health systems for the most vulnerable. My experience with the health system is much longer than my professional life. I grew up with a mother who was a nurse working in a private, not-for-profit place, who also had a small clinic. I still clearly remember verbal autopsies and stories of how women died. The women with babies that flocked to the health facilities and my mom's clinic, who needed treatment interventions, but always had the difficulty meeting the bills for care. As a young boy, I did not inquire into the death and barriers that women were facing daily. I was not a lawyer and not an activist yet. I grew up knowing child delivery as olutalo lw'abakyala, that's in my language. This means it's a battle for the women. Going through child delivery was and is still a matter of life and death. I also remember a number of cases that involved young girls and that sometimes married women that died after unsafe abortions. Emergency care for obstetric care after unsafe terminations were common then and continue to be common today. Lack of access to contraceptives, deplorable maternal health services, and a highly restrictive legal environment on access to safe abortion services continue to dominate our health system to date. As a lawyer and a social justice activist now, I keep wondering, why do women and girls continue to face disproportionate gaps in access to care and rights? Why has the global community not done enough? In Uganda, for instance, we still lose 16 women each day to preventable issues in pregnancy and childbirth. I have witnessed, advocated, and even litigated cases in which women are struggling to have what would ideally be basics for controlling their bodies, from access to maternity kits, to supporting safe deliveries of women and their newborns, to contraceptive methods of their choice. I note and I agree that a population's health and well-being is primarily a national responsibility, Mr. Chairman. But at the same time, I note that the health is also a global responsibility, which creates duties on other states to ensure a safe and healthy population, with particular attention to the needs of the world's poorest people. This particular responsibility on other states is often misunderstood, underrated, abused, and lately treated as part of politics. The reinstatement of the expansion of the global gag rule, Mr. Chairman, demonstrates how a repressive political decision from another country can affect population health and well-being in countries like mine. The global gag rule has affected and has led to cutting off funding for much-needed health services, especially among the communities that are already underserved. As a result of the global gag rule, my organization has lost key advocacy sub-grants. We had to close our work halfway into a 4-year USAID project on advocacy for better health, despite progress and good performance. The accusation then was that we are interpreting laws, a work that a lawyer does every single day. So the reason cited then was that we had failed to sign the addendum that incorporates the global gag rule. The closure of these projects brought an immediate termination to our advocacy interventions, and some of these promoted accountability in the supply chain of essential medicines in Uganda, including antimalarials and HIV testing kits. The goal of our work was ultimately to ensure patients had access to the needed facilities where they access them. The closure also meant immediately terminating contracts of our key project staff and distortion of coalition work that we were doing with other organizations that hold the government accountable on health systems. It is not an easy choice, Mr. Chairman, to simply comply and keep the resources, or simply make a choice to lose the access to these resources. Jobs and indeed lives are on the line. Nonetheless, my organization's work cannot be just on one area of health and not another. I think this would highly compromise the values of the institution that we have. Through my work, I can make the following conclusion, Mr. Chairman. I have witnessed a clear linkage between politics, the law, and health outcomes. In the area of reproductive rights, it's undeniable that political decisions have played a critical role in shaping the development of reproductive rights approaches and indicators for women. Unfortunately, our fundamentalism sometimes has continued to dominate over women's, girls', and mothers' health, especially when it comes to their ability to decide when, if, and how many children to have. Maternal and reproductive health should not be a privilege for some, but a right for all. My hope for Uganda, Mr. Chairman, and the committee is Uganda and the world that is where a future of women and mothers and girls, no one dies of them simply because of their biological composition. Thank you very much.
Thank you very much, Mr. Mulumba. Ms. Boss.
Chairman Engel, Ranking Member McCall, and members of the committee, thank you for this opportunity to testify today on the important issue of women's health. I greatly appreciate your interest in this topic and hope that my testimony today will shed some light on how faith-based organizations like World Vision are prioritizing and improving the health of women, girls, and their families around the world. As one of the largest faith-based organizations working in humanitarian relief and development, World Vision's work reaches vulnerable children and families in nearly 100 countries around the world. We have nearly 1 million private donors across every state and congressional district, partner with over 16,000 churches around the country, and work with a wide variety of corporations and foundations in addition to public donors like the U.S. government. In our work, we seek to ensure that every child has the opportunity to reach their full potential, and a healthy start in life is crucial to transforming the lives of children and their families. World Vision is a pro-life organization, and we believe that human life begins at conception. We do not take a position on the Mexico City policy and have not taken a position on this policy under any administration. Given that World Vision is a child-focused organization, much of our work on women's health is focused on maternal health, ensuring that a woman's reproductive years are also her healthiest years. In seeking fullness of life for every child, we believe all mothers and their babies deserve to have the basic information, medical support, and care needed to ensure safe deliveries, protection from preventable disease. But we also work on many issues impacting adolescent girls as well, including programs that address child marriage, early pregnancy, and menstrual hygiene. We should be proud of the progress that has been made in women's health and maternal mortality and the significant contributions of the U.S. government to that effort. But we cannot rest in this work. Progress is possible, we've seen it, but it's also fragile. We know from experience that vulnerabilities in health systems are easily exposed in crisis or disaster. We know that climate change will continue to impact health in growing ways. We know that there are places where appropriate resources and services are still not accessible. We know that we have challenges with quality and equitable care. To drive all of this, I cannot emphasize enough the need for better data. Legislation that this committee has supported, like the Foreign Aid Transparency Act, has focused on improving data from USAID, but quality global health data that show what interventions are being supported by USAID and where are still lacking. As an implementing organization, data are crucial to our own decision-making and program design, not to mention how important it is to taxpayers who are funding these investments. I would also like to emphasize a point that you will find throughout my written testimony, which is the critical role of faith leaders in addressing global health challenges. Faith leaders have considerable influence in their communities. Unfortunately, like other leaders, some faith leaders spread misinformation, creating social barriers that prevent women from visiting health facilities, getting tested and treated for HIV, and using birth spacing methods. Misguided influence can also encourage child marriage and the poor treatment of women and girls, and discourage the involvement of men in maternal and child health. Our training process for faith leaders replaces misinformation and stigma with truth and acceptance. Our program teaches about birth spacing and the importance of good nutrition for children and pregnant women, encourages greater involvement of men at all levels of health, and addresses difficult issues such as HIV and gender norms. We have a moral imperative to transform the lives of women, girls, and their communities to give them good health, hope, and opportunity. I hope this hearing today will help us all recommit to this work and unify us around our shared goals. I look forward to our continued discussion and any questions you might have.
Well, thank you very much, Ms. Boss, and thank all of you very much for excellent testimony. I'll now recognize members for 5 minutes each, and pursuant to House rules, all time yielded is for the purposes of questioning our witnesses. So I'll start by recognizing myself, and let me say, as I mentioned in my opening statement, I'm very disturbed by the administration's reimposition and expansion of the global gag rule. In 2018, the State Department released its 6-month review of its policy, where they claim that there have been no service disruptions due to the policy. Yet that is not consistent with what we've heard from the field and seen in the media. So let me start with you, Dr. Cates. What have you seen in the research that has been produced about the expanded global gag rule, and what do we already know from previous versions of the policy?
Thank you for your question. First, I wanted to say on that 6-month review that you mentioned, the review also noted that it was too early at that time to assess impacts. So there's another review that is expected, which might have more information. I can tell you some of the analyses we've done at KFF and some of the other analyses that have been put out. One of the things we looked at when the policy was first put in place and expanded was how many of the countries in which the U.S. provides global health assistance have abortion laws that are more permissive than the Mexico City policy would allow. So in other words, where is the U.S. working where there might be policies of the U.S. at odds with country policies? What we found at the time was that more than half of the countries in which the U.S. provides bilateral global health assistance did have an abortion law that was more permissive than the policy in at least one case. We've just updated that to the more recent period and found a similar finding. So that just shows that it presents potentially some challenges for providers and others working in those countries where there's a difference between their country policy and the U.S. policy. We've also looked at the number of non-governmental organizations, foreign non-governmental organizations that may be subject to the policy, because we were interested to see what does the expansion look like potentially. We looked at this soon after it was announced, and we found that conservatively, there were probably around 1,300 at least NGOs, foreign NGOs, that were subject to the policy. And this is a conservative estimate because it is very challenging to get data on subrecipients of U.S. support. What we also found is that most of these NGOs were newly exposed to the policy for the first time, so they had not had to take a position on the policy when it had been in place in prior iterations. In terms of studies that have come out, probably the most well-known and largest that's been done was just published in The Lancet last year. It's a large-scale empirical economics analysis that looks across the periods of time to better understand when the policy has been in effect. Was there a correlation between the policy and health outcomes? This is often a challenge to look at. You have to look retrospectively. What this study found was that there was a pattern when the policy was in place. Abortion rates went up, pregnancy rates went up, and contraceptive prevalence went down. There was also a recent analysis that was done by AmFAR and Johns Hopkins University in which they surveyed PEPFAR implementers to assess were PEPFAR implementers who were newly exposed to the policy having to adjust what they were doing, and what they found was that a third had actually altered their operations, including service delivery, and that included services like HIV testing, TA, things that were important for the HIV response, closing a youth-friendly clinic. And in one particular district in one country, a major provider of voluntary medical male circumcision had actually stopped providing its services, leaving a gap there. Human Rights Watch has also put out studies showing that they have found that providers have canceled services, including things like cervical cancer and HIV testing. And finally, PAI has released several studies from the field finding similar results. I think this is an ongoing thing to look at to be able to assess what the policy's impact might be on actual lives of that the U.S. is trying to save and reach.
Thank you, Dr. Cates. Let me ask you, Ms. Crocker. The humanitarian system today is facing a whole array of crises, from Venezuela to Syria to Yemen, and we see time and again across these conflicts the outsized impact they have on women and girls. Can you highlight, Ms. Crocker, some of the ways women's health is uniquely jeopardized in conflict?
Thank you for the question, Chairman. Women face a range of additional health challenges in the face of conflict, which include increases in gender-based violence, including intimate partner violence, and things like access to family planning. Health systems are always degraded further during a conflict, and as I noted in my opening statement, women both have some unique challenges that they face, and also are often the last to be able to get assistance, either to reach it or to have assistance given to them. And so what we see time and again, for example, just yesterday we released a statement with a number of other big NGOs about the situation in northwest Syria, where over the course of 2019 in northern Syria as a whole, 85 health facilities were targeted. CARE has been running a maternity and pediatric hospital in northwest Syria, which we just had to suspend services at due to a nearby hospital having been hit. But because so many hospitals in the surrounding area had been hit, this hospital was sort of being flooded with people in need of care. And we're seeing, almost 1 million people now in northwest Syria because of the increase in violence there who have been displaced. And these situations always impact women and girls more. In camps, some things that sort of are not always top of mind but end up being incredibly important to the health of women and girls include questions around placement of water and other commodities that are needed. When they're placed very far away from the center and women have to go, it places them at additional risk of facing gender-based violence, as an example. And again, because health systems generally are degraded, it means that things that women just need, such as access to family planning, access to contraceptives, things that over the life of CARE's work have been shown to be the #1 thing to help prevent maternal mortality, are just more challenged.
Thank you very much. I'll now call on members for questioning. I'll start with Mr. McCall, our ranking member.
No, thank you, Mr. Chairman. I want to thank all of you for being here today. The NGOs are really vital to our missionary work across the world, and You really do God's work here on earth. Kaiser Foundation, CARE, World Vision, and sir, what you do in Uganda is to be commended. Ms. Crocker, thank you for mentioning the bipartisan nature of this committee. We've accomplished, I think, more than any other committee in this Congress and in this very partisan, hyper-partisan time in our history. And I want to list some of those accomplishments because I think it's worth mentioning, Mr. Chairman. We reauthorized PEPFAR, which we know is saving millions of lives. We passed the Global Fragility Act when you talk about conflict. This is an attempt to bring our State Department, USAID, and Department of Defense together to stabilize those destabilized nations, particularly in the Sahel region, where the conflict is getting worse, not better. And we know when that happens, it impacts women first. The Global Hope Act, as I mentioned, Mr. Mulumba, I'll be in Botswana in 2 weeks to visit the Texas Children's Clinic. And they're also in Uganda, in your country, introducing the pilot program to do what we did with PEPFAR and HIV, with childhood cancer, building on the infrastructure that we laid with the PEPFAR HIV program. We just passed on the floor the other week the Keeping Girls in Schools Act, which I think it was stated by one of my colleagues from the military that the most powerful weapon against extremism is a girl with a book and education. We passed the Women's Economic Empowerment Act to help boost women's rights and economic rights throughout the world, particularly in Africa. And then finally the Child Marriage Act, where we see children at the hands of their governments getting married at a very, very young age. And so I guess I'd have a lot of questions asked, but one with respect to World Vision, Ms. Bosch, you mentioned, and I appreciate the faith-based nature, and I think the faith-based community is very generous and is leading. But you mentioned in some countries how they work actually against women's treatment. And I wonder if you could expand on that, and which countries are you talking about?
So when we're talking about, I think, access, which I hope is what you're getting at a little bit, access for women to care, there are often a lot of misperceptions about what it means to go to a health facility. Sometimes those are cultural barriers, sometimes those are religious barriers. There's a lot of misinformation that happens in communities, and we found that through HIV programs, gender-based violence programs, early marriage, pregnancy and family planning issues. So really what we feel is important, and the role that we can really play uniquely at times as a faith-based organization, is how are we working with those faith leaders who play such a critical role in either sharing good messages with their community or sharing, at times, misinformation. So the trainings that we do through our program model are really critical. We use biblical text. For pastors, we use the Quran when we're working with imams in Muslim context. So this is an interfaith approach, depending on the context, just to make sure that churches, faith leaders, because of the role that religion plays in people's lives, that's not serving as any sort of barrier for women to get the care and the services that they need, both for themselves and for their children.
And with the remaining time, I have Ms. Crocker and Ms. Cates, and Mr. Mulumba, if you care to talk about this. How can we, what are kind of some lessons learned of these private-public partnerships? And, where do you see improvement? How can we do a better job?
Thank you for the question. It's obviously, we have to do something different in the future to have greater impact, right? So public-private partnerships are one that the U.S. government has pursued, and some have been quite successful. One I want to highlight is PEPFAR's DREAMS initiative, which was started a few years ago, and the idea behind it was that because adolescent girls and young women are so vulnerable to HIV, much more likely to become infected, 6,000 new infections a week among young women. This is a population that faces multiple barriers, many of which we heard. What PEPFAR decided to do was to try to reach that population with all of the supports and address the structural challenges they may face, lack of education, as you were talking about, challenges with income, needing to find ways to have access to employment. How could PEPFAR do that? PEPFAR formed a major public-private partnership, working with many private companies and donors to really build this idea out, and has since been able to expand it to 15 countries. What's really exciting about this initiative is that the data show that it's actually working. New HIV diagnoses among young women in the districts that the intervention is in are going down. And that's a really important thing. So the public-private partnership has leveraged commodities, it's leveraged other platforms, it's leveraged other sectors. I actually heard Ambassador Burke speak yesterday about this, and she talked specifically about the education sector and her intention to look to other donors who are specifically working in that sector to build on what PEPFAR has done. It's very clear that those kind of partnerships, whether it's with private companies, foundations, other governments, are really essential.
Ms. Crocker, just very briefly.
Thank you. I think I'll pick up on maybe two things. One is just, in addition to some of these sort of larger public-private partnerships that were just discussed, we have seen real success as CARE, for example, in the Great Lakes region, using village savings and loan groups and other forms of collective action to mobilize communities and to, importantly, engage men and boys to tackle social norms, which, as you know, are so often what underpin some of these gender and power inequities that lead to things like increased gender-based violence. And the other thing I wanted to just pick up on was your mention of women's economic empowerment, which this committee has taken such a lead on, and just the important link between women's health as an underpinning and a basis for a healthy economy. And so as the committee continues to pursue the importance of women's economic opportunity, just to make sure that, that we all acknowledge and understand the importance of the link between a focus on women's health, including women's health in humanitarian emergencies and development settings, and what that can do to help further women's economic empowerment.
That's excellent. Thank you so much for what all of you do, and I yield back.
Thank you, Mr. McCall. Mr. Seres.
Thank you, Chairman, for holding this hearing, and thank you for our witnesses being here today. Ms. Crocker, CARE released a report last year indicating that Venezuelan women and girls migrating to Colombia are extremely at high risk of gender-based violence and human trafficking. And in my trip to Venezuela and Colombia last year, I spoke with single mothers who were deeply concerned about their safety and their children. Can you speak about the dangers facing these women and children as they flee this crisis? And what else can we do as the U.S. and international community to help women and children in this area?
Thank you so much for the question. There are, as you are probably aware, 4.7 million refugees and migrants already from Venezuela, and an expectation that there will be 4,000 people a day fleeing that country over the course of 2020. And this is due to numerous factors that you're very familiar with that are bedeviling the country of Venezuela right now. And what CARE found in that rapid gender assessment that we did on the Colombia and Venezuela border was almost a normalization of gender-based violence against Venezuelan refugees and migrants that are leaving that country. And what we're also seeing is that many of the health systems in a number of the host countries, which are already overburdened, for example, in the Colombian city of Cucuta, births have increased by 150%, and maternal morbidity has increased by 71%. And for those that remain inside Venezuela, there are also increasing challenges. For example, much more difficulty in accessing contraceptive care and contraceptive services. The price of contraceptives is estimated to have increased 25-fold in the past 5 years inside of Venezuela. And quality prenatal and delivery services are difficult to obtain, which is, of course, partly why, as you know, so many Venezuelan women are ending up fleeing or going across the border and having to come back. So it's very important. It's an enormous crisis at the moment that is not getting enough attention from a global perspective. And so, the totality of the crisis is something that we need to be more focused on as both a priority, a place for greater U.S. leadership, as well as global humanitarian funding. But very important to also recognize the ways in which this particular crisis is really impacting women and girls in a very direct way. And so I really thank you for raising that issue, because it is one that CARE continues to be focused on. We're also doing rapid gender assessments throughout the region to look at the health impacts of Venezuelan migrants and refugees who are leaving and ending up in a number of other countries across the region as well.
I read an article in the New York Times that was stating that children at the schools were fainting because of lack of food and lack of medicine. I wonder if you can talk a little bit about that.
I saw the same story. I don't have firsthand knowledge of that. But I think, you know, what we're seeing and what certainly the UN and a number of NGOs have been seeing and reporting coming out of Venezuela is an overburdened health system and, you know, crumbling public institutions and services and capacities, a crumbling economy, right? And all of these things lead to inability to access basic services, both inside of Venezuela itself as well as for those who are fleeing. And so, you know, it's shocking when we read reports like that, and I think it only highlights the need that we should all be, you know, the need we all have to be paying attention to what is going on right near us. And to be paying appropriate attention and again, focusing on the funding and the prioritization that is needed to address the real dire humanitarian challenges inside of Venezuela, as well as the needs of those who are fleeing the country.
Just a quick question. I know that the Venezuelan issue is not just Colombia. Now it has expanded into the other countries in the region. And not enough attention seems to be focused there, because those countries really do not have the ability to take in all these migrants. And the health issues, they can't deal with it because they have their own population to deal with. And I just don't see the world coming to the aid of this travesty that's happening. Thank you very much.
Thank you, Mr. Ceres. Mr. Smith.
Thank you very much, Mr. Chairman. Mr. Chairman, on Friday, there was a White House event that we were at, a few of us, including the ranking member, marking the 20th anniversary of the Trafficking Victims Protection Act. I am the prime author of that bill. It has saved countless women and children and many men stuck in labor trafficking especially. And none of you have mentioned that. I do hope you will speak to that issue, because I do believe modern-day slavery is one of those heinous crimes. It is disproportionately focused on women, and I have met many women who have been trafficked. I've had hearings with trafficking victims, and they need our love, our concern, and they certainly need rescue. Secondly, according to the World Health Organization, between 2000 and 2017, the maternal mortality rate declined by 38% worldwide. And also, according to WHO, the majority of maternal deaths can be prevented if women give birth in hospitals or are attended to by skilled health personnel with access to emergency obstetric care. And safe blood is very much a part of that. I do believe that USAID has embarked, and this is part of PEPFAR as well, to try to provide a means to assist these women. Countries should have a plan, communities should have a plan, so that a woman is pregnant, particularly in the final 3 months of that child's life before birth, that she will be attended to by someone if there is a problem, so that we can dramatically continue to reduce maternal mortality. Let me also point out that PEPFAR was the brainchild, frankly, of George W. Bush. And this man over here, where is he now? Okay. My good friend and colleague, Henry Hyde, joined by Tom Lantos, in a bipartisan way, pushed through the PEPFAR legislation. And that has saved countless Africans and others from the horrible death due to that terrible disease called HIV/AIDS. Also malaria and the other issues that are attended to it, opportunistic infections as well, have been greatly mitigated. In 2018, I was the prime author of the reauthorization for 5 years of PEPFAR, joined by Barbara Lee and a group of bipartisan lawmakers, so that about $30 billion roughly, will be authorized and hopefully appropriated to help those. Now, one of the points that is brought out that women represent the majority of those served by PEPFAR. ARV therapy, for example, 66%, or 9.8 million of those with ARV therapy were women. And I think that is a great thing that this policy is having such a positive impact. Now, on the Protecting Life and Global Health Assistance, that legislation, or that policy, I should say, is designed to ensure that U.S. taxpayers don't subsidize foreign, non-governmental organizations that perform or promote abortion as a method of family planning, and build on what was originally called the Mexico City policy created by Ronald Reagan. In 1985 and 84, I offered amendments on the floor to affirm the policy, and there was widespread statements made on the floor in debate that nobody will accept this. Well, the 6 months reviews found 99.5% of the people that we want to support accepted those pro-life guidelines. Let me also point out, the issue of abortion, we forget somebody when we talk about that. I do believe we need to care for both. We need to love both, mother and baby, and do everything humanly possible to ensure that there's a safe delivery. I'm the author of the Pain-Capable Unborn Child Protection Act. We know beyond any reasonable doubt that unborn children feel pain at least from the 20th week on, and maybe even earlier. And because of prenatal surgeries, children ought to be seen as another patient. The unborn child, the other patient, along with the mother when they present to a healthcare professional. So the Abby Johnson, some of you may have read her book, maybe not, maybe this panel has or hasn't, but she was a Planned Parenthood activist, ran a clinic, an abortion clinic in Texas for 8 years. When she assisted in an abortion, and this was the first where there was an ultrasound-guided abortion, she held the probe, and she saw that baby dismembered right before her eyes. She walked out the door and said, I will never be a part of this again. Now she's a very articulate spokeswoman for the pro-life cause. Birth is an event that happens to all of us. It's not the beginning of life. Ultrasound has shattered the myth that somehow there's no baby there. So I would encourage you. Murdered Nathanson, the founder of NARAL, one of the 3 co-founders, he said, I've come to the agonizing conclusion that I presided over 60,000 deaths. He wrote that in the New England Journal of Medicine and became a strong pro-lifer. Let's affirm them both. This policy affirms them both and says contraception, this doesn't cut it by $1. It says that who we support, not just what, matters. And if a group is trying to bring down pro-life laws in other countries or provide abortion, perform dismemberment or chemical poisoning abortions, we got to look at the fact, just like Abby Johnson did, and say, what actually happens in that abortion? A baby is dismembered, or a baby is killed. RU-46 first starves the baby to death, one of the chemicals, and the other provides an expulsion of the child from the womb. These children deserve better. Women deserve better. And, I would ask Mr. Mulumba, do you know what the 3 exceptions are to the Protecting Life and Global Health Assistance are? Because you turned down the policy.
Thank you, sir, for the question. My expertise is on the implications of the policy back home.
So you don't know the 3 exceptions. I'm really out of time, so I want to. The exceptions are rape, incest, and life of the mother. We don't want family planning abortions, and that's what the policy, starting with Ronald Reagan, was designed to ensure.
Okay, thank you, Mr. Smith. Mr. Berra.
Thank you, Mr. Chairman. I disagree with my colleague on the perceptions here, but there's a lot that I've heard today where we actually agree on. I'm glad that the minority party really cares about maternal health. I'm glad that they care about child health. I'm glad that, we heard the president last night talk about wanting to invest millions of dollars in reducing maternal health. Our foreign policy should be based on American values and what we think about. And if we think about American values, 65% of women aged 15 to 49 use contraception methods. 99% of women who have been sexually active at some point have used contraception. Those are American values. And that's voluntary family planning. They're choosing to use those methods. We talk about being a faith-based nation. 98% of Catholic women have used modern contraception. 99% of Protestant women have used modern contraception. Those are American values. So we're talking about making voluntary family planning available around the world to reduce maternal mortality, to reduce child mortality. In developing countries, when you do proper pregnancy spacing, from 1 year to 2 years, you nearly have infant mortality rates. So we all should agree on making voluntary family planning available to women around the world. One of the most effective things. I'm glad that the ranking member talked about the things that we've passed. PEPFAR, the Global Fragility Act, particularly focused on the youth bulge in sub-Saharan Africa, focused on fragile states in that region. The one thing that we actually could do to address the youth bulge is make voluntary family planning readily available to empower women. The Keeping Girls in School Act, the one thing we could do is to make sure there isn't that unintended pregnancy by making voluntary family planning available to those young girls. Women's Economic Empowerment Act. If we actually want to have impact for women around the world, we ought to put them in charge of their own reproductive health and allow them to do active pregnancy spacing. Dr. Cates, let me ask you a question. When you look at the impacts of the global gag rule, both in past years and through this administration's expansions, has it limited access to voluntary family planning?
So as has been mentioned, the policy the U.S. policy supports voluntary family planning. That is part of policy, and the U.S. provides funding, is the largest donor of that area in the world. But as I pointed out, the implementation of the policy has presented barriers, and there's been documented studies going into the field and talking to providers and looking at what has happened and doing surveys to say that they have faced barriers in being able to implement the programs that they are legally able to provide. They've lost partners, they've closed services. So it's not as simple as something is funded and the policy doesn't affect that. I think that's the complication here, and what is very hard to assess, but is clearly being seen in the field. The study I mentioned from The Lancet is important to note because it looked back in different periods to try to say, is there a relationship between certain health outcomes, because ultimately that's what we're looking at, right, health outcomes, and the policy, and it found a pretty strong relationship. That definitely warrants further attention, because one of the challenges is if we can't immediately measure health impacts, we might not see the negative effects, if there are any, for years to come.
Yeah, my impression is the way the administration's implemented the global, it has had this rebound effect, closing family planning clinics and et cetera, and limiting access. In the limited time I have left, Ms. Crocker, I had the chance to visit the Zaatari refugee camp in Jordan with CARE and visit the maternity clinic that UNFPA is running. It was a pretty amazing facility. There was State Department funding that helped start it, and of the 7,500 babies that were born at the time that I visited, there wasn't a single maternal death. Pretty impressive. That's what UNFPA can do. Is that clinic still running, and what is the impact of our not properly funding UNFPA?
Thank you for the question, and I'm so glad you had the chance to travel with us. The clinic, happily, is still operating, and now there have been 12,000 live births without a single maternal mortality at the Zaatari camp, over 12,000 live births. Until the U.S. stopped funding UNFPA in 2017, every bassinet in that camp displayed a U.S. flag. As of July 2019, UNFPA was facing about a $200 million gap in the over $500 million that it had asked for to date by that point. And so while some other donors have stepped in to try to help fill the gap that since the U.S. has stopped funding, there still is a very significant gap. What we can talk to is the incredible good work that UNFPA does around the world in over around 150 countries. And most particularly, I think, with a focus on what they do in humanitarian response, where they are sometimes the sole provider of quality reproductive and obstetric care, but they do even more than that. So in the ways in which CARE partners with them around the world, They do everything from providing clean birthing kits to training midwives to dealing with gender-based violence to dealing with prevention and treatment of sexually transmitted infections, as well as, again, the very important access to both family planning and reproductive health care in ways that are deeply needed in the context of humanitarian crisis and in certain circumstances where UNFPA is the only operator providing those services.
Well, so if we actually care about maternal health, if we care about child health, if we care about empowering women and girls, we ought to fund UNFPA.
Thank you. Mr. Chabot.
Thank you, Mr. Chairman. Ms. Boss, I'll begin with you if I can. Back in 2003, I was the lead sponsor in the House on the Partial Birth Abortion Ban Act, which went all the way to U.S. Supreme Court. President Bush signed it into law. It was appealed, went to the U.S. Supreme Court, and it was upheld in the Supreme Court. I've also been a longtime supporter of the Mexico City policy, both in this administration, and I'd like to thank President Trump for that, and under President Bush's administration. So if I could ask you this, has the administration's Protecting Life and Global Assistance rule impacted your ability in any way to provide life-saving treatment and other health services to women across the globe?
The short answer to that would be we have had some additional administrative requirements, but we have our own internal policy, again, as a pro-life organization, where we neither receive nor give funding to organizations that provide abortion. So from a practical operational standpoint, in our programs, I'm not aware of any impact, but there has been some administrative, slight administrative burden. We have to ensure our partners are complying so that we can continue doing the work that we want to do.
Okay, thank you. Ms. Crocker, let me turn to you for a different question. A few Congresses back, Senator Rubio in the Senate and myself and some other members here in the House, it was a bipartisan bill, passed legislation, the Girls Count Act, which in essence encouraged the State Department to work with other governments to make sure that children, especially girls, were actually registered upon their birth. We've seen time and again where if especially girls aren't registered, they basically can disappear into all kinds of horrific circumstances. They can be trafficked, international gangs. People don't know they exist, and so they can be sold off into horrific circumstances. So, excuse me, could you discuss how birth registration or lack thereof could impact access to health care for women and girls?
Thank you for the question. It's not actually something that I'm expert in or have knowledge of myself. So I wonder if I might ask if my co-panelists might be able to come in and address this question. Perhaps our witness.
Somebody else wants to handle it. I'm happy to hear about it. Yes, Ms. Bosch.
I'm happy to jump in, Mr. Sheba. I've seen some of our birth registration programming in Kenya. It really is vital, and thank you for championing that issue, because if any child doesn't have a birth certificate, the lack of access to education, to health services, it's really as if that child doesn't exist. So it's a critical piece. It's something we're trying to grow our programming in, just recognizing the barriers that follow that child if they don't have that simple piece of paper at the beginning.
Thank you. And then one final question, similar to that, Senator Rubio over in the Senate and myself and others here in the House pushed a bill and called the Protecting Girls' Access to Education Act, and it was also signed into law by President Obama, which seek to promote education in conflict zones, in conflict settings. In your work, do you see a correlation between access to education and access to health care?
Absolutely, and we found that the lack of access to formal education really does increase vulnerabilities, especially for girls. Being in school actually helps protect them from gender-based violence, early marriage, early pregnancy, so it's really critical. Right now in places like Bangladesh, we're working in Cox's Bazar, there is not formal education. We're working with UNICEF on some informal mechanisms, but it's really an important issue in these protracted crises, working with displaced populations, access to formal education is a huge need.
Okay. Thank you very much. Mr. Chairman, I yield back.
Thank you, Mr. Shabbat. I now recognize myself for questioning. Last fall, I was in Bangladesh with CARE on a trip there, and our trip mainly focused on nutrition. So I wasn't expecting to hear about the impact of the global gag rule. But one of the partners we met with highlighted the global gag rule as a barrier to their work. Bangladesh is a country where more than 1 in 3 children under the age of 5 suffer from chronic malnutrition. But I heard of cases in which the U.S. could not allocate precious global health dollars to the organization best suited to meet the needs of those 5.5 million children. Tragically, we are only able to fund groups willing to operate within this administration's extreme ideology instead of our most trusted, capable, and experienced implementers. Dr. Cates, I was surprised and disturbed to see the far-reaching impact of this harmful policy. Would you talk us through the scale of the expanded global gag rule outside of family planning and reproductive health programs, narrowly speaking?
Yes, thanks for the question. So the policy, as announced in 2017, expanded upon all previous versions, and now it encompasses virtually all of U.S. Bilateral global health assistance. So that means anywhere between $7 and $8 billion a year, depending, to the extent that that money goes to a foreign NGO. This includes HIV programming, maternal and child health, nutrition, as you mentioned, President's Malaria Initiative, all of the sort of main areas that the U.S. works in. So that's open up a whole new set of programs. We've also, as I mentioned earlier, have looked at the number of NGOs that might be affected, and we found that conservatively it's at least 1,300, probably many more, because there's so many other subrecipients.
Oh, 1,300 NGOs affected.
In the sense that they would have to certify or make a decision about compliance with the policy. And I think just to pick up on something you said, what we have seen in studies and other things is many of these implementers are quite confused about the policy. They're not sure if it applies to them, what it means for what they do provide, and some have over-implemented it, meaning that they think that they can't do a service when they can, and that can create service challenges. One of the other challenges of that to think about from the perspective of a barrier, as you mentioned, some of these partners are the most trusted in their communities and are the places maybe the only provider in a particular part of a country. So affecting their ability to participate in the program could really affect the reach of the U.S. government for its health goals. And then finally, one other thing I'll mention, importantly, PEPFAR right now is putting a big emphasis on localization and really trying to build capacity in local partners. USAID is also moving towards the journey of self-reliance. These are critical things to be focused on for sustaining capacity and building capacity in countries so that the U.S. hopefully can work itself out of a job in these areas. If you lose partners or if partners are unsure about their ability or make a decision not to participate, it could really impede that effort.
So we're shooting ourselves in the foot. All right, well, Ms. Crocker, CARE works with many partners across various programs that support women's empowerment. Is it typical that organizations would work across a range of women's health, education, economic empowerment, and political engagement issues?
Thank you for the question, and I'm so happy that you also had a chance to travel with CARE. And yes, I mean, I think you will find both at the international level as well as at the national and local level organizations that do work across a range of issues, including CARE is one. And so while it's unfortunate, I think it's not surprising to hear that there are implementers who may be affected by the policy when their focus might be, in the case that you were looking at nutrition as an example.
So there'd be negative ripple effects across a range of policy areas. Yeah, given the shortness of time, I just wanted to offer Mr. Mulumba a chance to answer as well whether you've seen impacts of the global gag rule reaching beyond family planning and reproductive health in Uganda, and whether reproductive health providers and advocates also work on other health and development issues.
Thank you so much. What I've actually observed is that much of the USAID funds that is withdrawn is not funds that were meant to be doing work on abortions. So what we actually observe is that people are losing out on resources which are making other interventions. In the case of the example that I gave you, the funds that we lost as an institution were for health system strengthening. And so the interventions that we were doing were affected. But we have also observed that those that are doing service delivery, they have had an immediate withdrawal from the communities where they are working. So the immediate withdrawal of services beyond reproductive health services to include services, because of the integration that everyone is talking about, it includes services like HIV/AIDS. So adherence to treatment becomes a very big problem. But you'll also observe that many NGOs work in coalitions. And so when NGOs are not clear on what the policy actually means, in Uganda we have not seen an intervention where, for instance, the US government is explaining what this policy is all about. So you find that very many people have heard about the policy, they fear it, but they don't know the boundaries of what the policy means. So working in coalitions is extremely difficult.
Thank you. My time's up, and despite the fact that I'm sitting in the chair, I'm going to move on to my next colleague, which is Ms. Wagner. You're recognized for your questioning now.
I thank you, Mr. Chairman. Let's be clear here. The purpose of U.S. global health and economic development programming is to recognize, promote, and protect the dignity of all individuals and to extend a helping hand so that the marginalized, poor, and vulnerable around the world may build a better future. The promotion of abortion is incompatible with this mission. Abortion is not health care. Children and families should not be enumerated as barriers to prosperity, but sources of strength and beauty, purpose, meaning, and potential. I am proud that the United States has recommitted itself to global health policies that recognize the inherent worth of all people and leverage the boundless human capacity for generosity, cooperation, and ingenuity to overcome global poverty. We will not make the challenge of ending poverty a little simpler in the short term by pushing women to end the lives of their children. That is not a compassionate position for either mother or child. We will not tell women that they must choose between their children and prosperity. Instead, we will work in partnership with countries around the world to ensure that all women and children have access to opportunity and success. The President's Protecting Life in Global Health Assistance policy ensures that American tax dollars are used for actual health care, not awarded to global organizations that push abortion on women instead of doing the hard work of helping these vulnerable women to have both their baby and their dreams. We must continue to build healthcare capacity in communities to fill any gaps left by these funding changes. And in this way, we can best serve women and children around the world. Abortion is both a symptom and a tool of the oppression of women. Research by the United Nations Population Fund indicates that widespread access to prenatal testing and abortion in countries with patrilineal and patrilocal traditions is linked directly to gendercide, the global epidemic of violence against women. 126 million women are demographically missing around the world due to sex-selective abortions, female infanticide, and gender-based violence against young girls. Sex selection abortions have been banned in many countries, the U.S. notably not included in those, but social pressures on women to eliminate their baby girls remain. In the northern Indian state of Uttarakhand, for example, 132 villages reported that no girls were born over a 3-month period in 2019. And the UK medical journal The Lancet has found that as many as 12 million baby girls were aborted in India between the 1980s and 2011. Ms. Boss, what is the role of abortion in accelerating the global gendercide?
In our experience, and we actually had a program on this subject in Armenia that we were very proud of, where really we did want parents and families and communities to understand both boys and girls have value, that they deserve love, that their lives had meaning. And so we really did have an approach that worked with both the government of Armenia and the Armenian church to address those challenges of really equal value of boys and girls and address that issue of sex-selective abortion. So we were very proud of that work. I think it's something we continue to look at ways we can contribute to both of those issues, really hopefully reducing sex-selective abortion and just lifting up the value of girls.
Thank you very much. My time is about to expire. I have many more questions that I will submit for the record, Mr. Chairman. Thank you.
Thank you so much, Ms. Wagner. I now recognize Ms. Houlihan for your questions.
Thank you, Chairman, and thank you very much to the panel for coming. I have a couple questions. My first one is the current administration has expressed support for women's economic empowerment, which I wholeheartedly support, but globally more than 1 in 5 girls is married before, 1 in 5 girls is married before the age of 18, which means the end of their formal education and the very beginning of motherhood. The UNFPA, along with UNICEF, runs the UN program to end childhood marriage. Unfortunately, the U.S. does not currently fund the UNFPA. I was wondering if you might be able to comment, Ms. Boss, on whether or not you can, the economic empowerment prospects of child brides, and why is ending child marriage central to women's economic empowerment, please?
Thank you, Congressman, for that question. You know, the economic benefits of girls being in school and not being put in the situation of being married early, there's a lot of data, a lot of evidence that backs that up. We actually did a report that we released last fall that included 4 case studies on child marriage across both development and humanitarian contexts. Speaking from our own experience, you know, the data's there, the evidence is there. I think we really need to, again, focus on keeping girls in school, and the committee's support of the Keeping Girls in School Act hopefully will be critical in enhancing the U.S. government's approach to really looking at the preventative measures we can take to reduce child marriage.
And so if the UNFPA is not there, especially in places like Yemen and other places that are war-torn, who else is there that can help with this particular issue?
It can be a challenge. I do think some of us who are in humanitarian contexts, CARE, World Vision, Save the Children, you know, we do attempt to address these issues as well. World Vision, we have had past partnerships with UNFPA. We don't take a position on the Kemp-Kasten policy per se, but there are contexts certainly where, you know, I think we've seen UNFPA contribute significantly to this kind of work.
Thank you very much. Does anybody else have anything to add on child marriage at all, or Dr. Cates?
Yeah, I would just add to those excellent comments that, I mean, we have to understand this has a tremendous health impact on girls when they are married young. It's not just the economic impact, it's the health impact on having children young. And so all of these are very synergistic. Investing in women's education, investing in economic opportunity, and investing in health serve the same goal.
Mm-hmm. Thank you. And my next question, sir, is for Mr. Mulumba. Can you describe the correlation between laws that are discriminatory between the LGBTQ community in countries like Uganda and the health outcomes for those communities, for women in particular?
Thank you very much. I think that one of the areas that has often come up as a difficult area in Uganda is the LGBTI issues. We've had a history of laws. Many of these are colonial laws that we still have even before the proposed introduction of the new legislation that was, we had the criminal law that criminalizes the acts. So the criminalization does not only affect the target people, but it also affects the service providers. So people and service providers have been put in a very difficult situation on how they go about LGBTI issues. So the laws, in fact, have become determinants of access to care. Where the laws are disenabling, then those particular populations are affected. And in the Ugandan context, the LGBTI community has really had a rough time. We know that part of the investments that the US government had done were to remind the state to even develop guidelines on mainstreaming LGBTI issues. But at the same time, the LGBTI community is just one of those that has been affected by some of the funding cuts that we've witnessed over the past years. Thank you.
Thank you. And I just have one more follow-up question for Ms. Is it Bose or Boss?
Boss.
Boss. So you sort of alluded to the fact that CARE and the World Vision Organization were trying to fill the void that UNFPA is not able to fill in some areas. Is that what you're intending to say? It sounded as though you were saying that there really wasn't a solution in places like Yemen to address these particular issues without the UNFPA.
I can't speak specifically to that. I don't know if Sheba Crocker is able to, but yeah, I don't know if there are gaps. I'm just not as familiar with that kind of programming. I do know that in some of the humanitarian contexts, there are other partners. I don't know that certainly that is addressing all of the gaps that there may be if UNFPA is not present.
Ms. Crocker, do you have a quick word to add?
Well, I would just note that there are some places, as I alluded to before, where UNFPA is actually the only provider of some services. In Yemen, for example, they are the only international provider of reproductive health services. And I also noted that they are currently facing a several $100 million gap in their funding in terms of what they've put out that they need. And so while I don't have at my fingertips exactly where those gaps might now lie, they are facing gaps because they just do not have all of the funding that they need to carry out their activities. And you know, as I noted, in humanitarian settings in particular, UNFPA does both incredibly important life-saving work, but is often the only provider on the ground.
Thank you. And as we know, and I will conclude with this, the UNFPA, the United States, were one of the founding partners of that organization, and we had provided until the last several years the third largest, I think, amount of resources, meaning money, to that organization. And if there is a gap, then that gap is probably coming from the places where it is no longer provided. And thank you so much for your testimony today. I yield back.
Thank you. We now recognize Mr. Perry for his questions. Mr. Perry.
I thank the gentleman and I thank the witnesses. I would like to expand the conversation, if you will. I don't think that women and girls can be successful or really even happy members of society when they face forms of gender-based violence, often resulting in physical harm to their bodies. I particularly want to highlight the impact of FGM, female genital mutilation, on women and girls. It is a harmful practice that severely affects a girl's health, development, education, and her quality of life. It is commonly performed on girls from infancy to 15 years old, leaving a lifelong impact on the most innocent among us. Girls who are subjected to FGM are more likely to drop out of school. Girls affected by FGM are also at increased risk of becoming child brides. Just last week, I heard of a devastating story in Egypt. You might be aware, a 12-year-old girl bled to death after having FGM performed. Her parents and her aunt made the choice to take this young, innocent girl to a private clinic, and I said clinic, to have the practice done, and she lost her life. This case exemplifies how difficult it is for the international community to end the harmful practice, because Egypt actually banned FGM in 2008 and criminalized it in 2016, yet Egyptians are still struggling to eradicate the practice. In the past year, we have FGM convictions out of the United Kingdom and Ireland. In the UK, a mother became the first person convicted of FGM in the country after she was found guilty of performing the practice. She performed it herself on her 3-year-old daughter. And in Ireland, a married couple was found guilty of carrying out the practice on their 1-year-old daughter. The practice has also been happening right here in the United States. We saw the 2017 landmark arrest of 2 Michigan-based doctors, I underscore doctors, accused of performing FGM on at least 9 underage girls from 8 to 13 years old. The majority of the victims were brought across state lines, all traveled with their parents. The testimony of the young, innocent girls included in the criminal complaint against the doctors, it's harrowing to say the least. 2 of the young victims believed that they were traveling with their moms to Michigan for a fun girls' weekend. I mean, that's the ultimate betrayal, in my opinion. The 2017 Michigan case was the first time the United States used our 1996 federal statute banning the practice. Unfortunately, the Michigan case resulted in the federal statute being ruled unconstitutional by a federal district judge. It has now been 16 months since a federal district judge ruled in the United States federal ban on FGM unconstitutional, putting the onus on Congress to pass new legislation. And indeed, tomorrow, February 6th, is the International Day of Zero Tolerance for FGM. Now, I propose legislation to not only reinstate a ban on FGM in the United States, but also to make our laws stronger to ensure successful prosecution in the future. And there's a new, I mentioned doctors in this, and the advent is not only overseas, but in the United States, where the terminology uses it's being medicalized, a medicalized felony practice. Ms. Boss, what message do you think it sends to the international community, including governments that have yet to ban the practice, that the United States does not currently have a federal ban on FGM?
I do think it's critical that the U.S. show leadership in some of these places where we are, oftentimes as implementers trying to enforce laws. There are many places, thankfully, where there are laws banning FGM, but you're right, there's a critical gap in how we enforce them, even in the work that we do. So we really are focused, again, on working with law enforcement, the judiciary communities, to really halt this practice, because the kind of tragedy that you mentioned, unfortunately, it's all too common. So, I do hope the U.S. continues to show leadership in this space and really continues to model really the best of what we want to do to the rest of the world.
I appreciate it. I do have I find it hard to find proponents, advocates of FGM, even in this body, but yet we can't seem to move a bill. And I get it, if they don't like my bill, one should be offered that they do like. I think it just absolutely, we have to send a very strong message. Ms. Crocker, Dr. Cates, do you have anything to add in this regard? I'm sure you work in the space as well.
I would just like to thank you for your focus on gender-based violence and the many different forms that it can take, including in the context of emergencies. And as I noted in my opening remarks, there is a bipartisan bill, the Safe from the Start Act, which would expand and strengthen existing U.S. government policy and efforts to support countering gender-based violence in its many forms. And we would strongly encourage passage of that bill.
I thank the Chair.
Thank you, and I now recognize Mr. Deutsch for his question.
Thank you, Mr. Chairman. Mr. Chairman, the Trump administration authorized, I think, what can only be described as a radical, unprecedented expansion of the Mexico City policy, the global gag rule, extending it to apply to all global health assistance, where previous iterations applied specifically to family planning funds. Earlier this year, Secretary Pompeo announced in a press conference that the State Department would be taking action to, quote, implement this policy to the broadest extent possible, close quote. But while the purported intention of the global gag rule is to reduce the number of abortions taking place, that's simply not the result of the policy. And Dr. Cates, you mentioned the new study published in Lancet that found that when the global gag rule was in effect between 2001 and 2008, abortion rates increased by about 40% among women in countries most affected by the policy. It also found a symmetric reduction in the use of modern contraception while the policy was enacted, coinciding with an increase in pregnancies. This pattern of more frequent abortions, many of which are unsafe in the impacted countries, and lower contraceptive use was reversed after the policy was rescinded in 2009, and it seems based on the research and our witnesses' testimony today, that not only does the global gag rule accomplish the opposite of its stated goal, but it puts women already at risk, poor women and women in developing countries, at further risk by removing their access to safe reproductive care, as well as restricting their access to quality health care more broadly. So, Dr. Cates, can you tell us more about the research and what it foreshadows for the impact of the expanded global gag rule if it isn't repealed?
So the research has, and particularly the study you were just citing from the Lancet, does show a strong correlation between this policy being in place and increased abortion rates, increased pregnancy, and reduction in contraceptive prevalence. And when the policy is not in place, the opposite. One of the challenges, and so that really suggests that there is a relationship here that really needs to be assessed, because that is not really what the goal of the policy seems to be. And as I mentioned earlier, there have been more recent, that is a retrospective analysis. There are current studies that have gone into the field to try to understand, is there disruption in services? Is there confusion? Is there maybe over-implementation? And those have been documented. I think one challenge that I heard Ms. Boss speak to, and I want to also echo, is that we don't always have at our fingertips the data we need to understand the impact on women's lives right now. And that would be one area I would look to you all to potentially strengthen, which is having a better sense of what's happening in the field with U.S.-funded programs, so we understand the impacts more in real time. This is something PEPFAR does quite well. It's not necessarily the case in some other global health programs. But just to come back to your question, there has been a lot of confusion about this policy, and the research, as you said, does suggest there's a strong relationship here.
Thank you, and I have more questions on this that I'll submit for the record. I just want to spend a moment to talk about the administration's repeated efforts to discontinue funds to UNFPA, the UN Sexual and Reproductive Health Agency, which provides essential women's health services around the world, especially where there is otherwise little or no access to care. As chairman of the Middle East Subcommittee, I'm especially concerned because of the agency's critical, irreplaceable, and life-saving work that's done in Yemen and in Syria. As we know, the humanitarian crisis in Yemen remains the worst in the world, and in a country where rising food shortages have left more than 1 million pregnant and lactating women malnourished, and where an estimated 114,000 women are likely to develop childbirth complications, the UNFPA is the sole provider of life-saving reproductive health supplies and medicines. And the importance of that work is also true at the Zatri refugee camp in Jordan, the world's largest Syrian refugee camp. At Zatri, the U.S., through this program, was a major supporter of the camp's central maternity ward, where UNFPA has facilitated over 12,000 births with 0 maternal deaths. Thousands of babies have been born healthy, many with American flags on their bassinets, thanks to the important work of the agency and thanks to the United States financial support for their work. That's something that I think on both sides of the aisle we should be proud of, and I worry that by the continuing attacks by this administration on UFFPA funding, that we will threaten those important and fragile global health gains. And I would like to just submit for the record the January 2020 report called Counting the 3 Transformative Results, which identifies the specific interventions needed to achieve 3 transformative results in women's and girls' health by 2030.
Without objection.
Thank you, Mr. Chairman. I'm so grateful for the witnesses for being here today to highlight a critical issue that this committee needs to address. And, Mr. Chairman, I appreciate the time. I yield back.
Thank you, Mr. Deutsch. I now recognize the gentleman from Tennessee, Mr. Burchett.
Thank you, Mr. Chairman. I'll try not to run over, and I'll just get to my point here very fast. As one of the longest-standing U.S. global health priorities, what have we learned from PEPFAR programs in terms of building health systems, accessing at-risk populations, and ensuring effective use of our taxpayer dollars? And I'll just throw that out to the committee. Any of y'all want to answer and take a shot at it?
I'll start. Thank you for that question. We've learned a lot from PEPFAR, and I can't possibly highlight all of the things we've learned, but some that I want to focus on. First of all, there's been a bipartisan commitment to this program from the start, and that is really important, sends an important signal to the field. So this program is seen as having lots of backing back home, and that's important. The other thing that PEPFAR has done from the get-go is really focused on both delivering the life-saving interventions that are needed, but figuring out how to do that in settings where there are no systems or were systems that weren't adequate. And that was a challenge, but there's been a lot that's been learned from that experience. PEPFAR has also done something fairly unique, which is it engages very regularly with civil society in both sharing information and getting feedback from civil society and how programming should be done. That's been an incredible effort that has led to better programming, and PEPFAR would probably be the first to say that. Something I mentioned earlier was data. We can't always know that we're doing the best thing and reaching the people that need help the most unless we have the information as close to real time as possible. PEPFAR is probably the best model we have in the U.S. government for doing that. There's been investments in that, and that's been another lesson. And then finally, I think PEPFAR has, through its leadership diplomatically, as well as its programming, send a strong message that you can't leave anyone behind, that to truly have the impact on HIV incidence and on reaching more people with treatment, you have to reach everybody. That's going to be hard, and PEPFAR recognizes that, but the program has a lot of lessons in that regard.
Any of the others?
I would mostly just ditto what Jen said. She said it very well. But just to add as well, I really do think because PEPFAR has focused so much on health workforce and health systems, we owe PEPFAR a lot of gratitude. The Ebola outbreak in West Africa would have been much worse had it not been for PEPFAR being present and on the ground. It was noted earlier, some programs, global health programs, are moving to localization. PEPFAR is one of them. How do we build the capacity of local partners? Again, the journey to self-reliance, that's a priority of the administration. We have to look at ways to build up local structures and local institutions, and PEPFAR really, I think, has prioritized that, and we could learn lessons from that across other programs.
Thank you. I remembered when the AIDS epidemic kind of came on and we had missionaries in our church come talk about it, and what impacted me as a young man was the fact that we lost entire, they talk about losing entire villages, but they lost entire languages because of just the outbreak was just so widespread. So thank y'all. So any others want to comment or out of y'all's wheelhouse?
No, I mean, certainly the life-saving benefit has tremendous impact. PEPFAR, when we started doing HIV/AIDS programming, pastors said, I just spend all my time going to funerals. That's my job. I don't actually preach. I go to funerals. And that was a tragedy. And I would say, I've been able to travel a lot of places where PEPFAR has been investing resources. People know that that support is coming from the United States, and their gratitude and their appreciation is real. So, thanks to the Congress for continuing to support that investment. People do appreciate it, and they know where it comes from.
All right. Yes, ma'am.
I just want to add, since the focus of the hearing is on women and girls and women's health, PEPFAR isn't thought of as a women's health program, but it actually serves millions of women each year and spends a significant amount of its resources on women and has done many innovative things to reach women and address the many structural challenges that women have. So I think it's really important that we're talking about it today and recognizing its role in that regard.
Yeah, I think also the fact that, when I was a kid, when the outbreak kind of happened, Rock Hudson, and it just kind of swept the country. Folks died. I had friends that died HIV and AIDS, and now that's just not necessary if we can get them the proper medication. So thank y'all for what y'all are doing for the least amongst us. We appreciate it so much. Thank you. Thank you, Mr. Chairman. Madam Chairman, excuse me. You slipped in on me. I yield back the remaining 14 seconds of my time. Please use it wisely.
We appreciate that. Ms. Spamberger, you're recognized now for 5 minutes.
Thank you very much, Madam Chairwoman, and thank you to our witnesses today. Thank you for your testimony, and thank you for your incredibly hard work on these issues that are so incredibly important to not just the United States, or to Uganda, but to the larger world. I will be joining many of my colleagues for an Asia subcommittee hearing on the coronavirus this afternoon. And experts agree that medical threats like SARS, Ebola, and now coronavirus pose a risk to U.S. national security and global security. And I have a background in the intelligence community, so I do tend to think about public health issues in a broader context, particularly that of the national security consequences. So it was discussed
the disproportionate percentage of girls that were impacted by Ebola, by women, or the disproportionate number of women impacted by Ebola in the DRC. And so I was wondering, Ms. Crocker, could you expand a little bit more on how many of these outbreaks do uniquely impact women?
Thank you for the question. And just to sort of start where we maybe ended is that for sure one of the lessons we learned from the Ebola outbreak in West Africa is the importance of making investments in primary health systems and infrastructure. And I think as Jen importantly took us back to why that's particularly important in the context of the hearing that we're having, the subject of the hearing we're having today. And women and girls face unique challenges in a number of different ways. We've discussed some of them: gender-based violence and sexual and reproductive health access. In addition, they are uniquely challenged when it comes to being vulnerable to contagious and infectious disease, both because of sometimes social norms and the role that they play within their own communities and within their own families, and because of the role outsized that they play in many countries around the world. It's estimated that at least 75% of the healthcare workforce is women, which is on the one hand a positive, on the other hand also means that they are the first line of defense often. But what we also see is, again, due to social norms and access issues that we've also discussed, women are often the last to receive care in the communities and in their families. And so it's sort of that twin, it's both aspects. It's both they're more vulnerable, they're more exposed, and they're the least likely to be first in line to receive the assistance that's needed. So again, it speaks to the importance of having a focus from the outset of humanitarian emergencies all the way through development programming on the health needs and protection needs of women and girls in particular. But it also anyway, sorry.
Well, and so drawing on that point that they're oftentimes the first or more exposed, but then among the last to actually get treatment, what does that do for these sorts of outbreaks in terms of our ability to contain them and address them? It sounds to me that it would actually elongate that process because of the fact that women are overly exposed and perhaps last to receive treatment. Could you comment on that?
Well, I mean, I think, again, it just speaks to the importance of making sure that we have the right kinds of assistance and support systems in place. And often we aren't thinking first and foremost about women's health needs when we think about responding to humanitarian emergencies. But we have certainly found that addressing the unique needs of women and girls, especially their health needs in the context of emergencies, is as important as things like food and water and access to shelter. And because they're often overlooked, I think, as you say, it sometimes then prolongs or means more exposure, and that women are even more vulnerable to things like contagious and infectious disease when we know they are already facing significant and unique challenges in accessing health care and because of the unique needs of women and girls in the context of emergencies.
And Dr. Cates, would you add anything in terms of what we could be doing in our health systems more broadly to improve our preparedness and our resilience against communicable diseases?
So the U.S. government has played a leading role, clearly, in global health security around the world, strengthening other health systems, helping to set norms, leading the global health security agenda. But clearly, there's going to be more outbreaks. That's a given. That's the one thing we know. There will be another outbreak after this outbreak. So what are the interventions that the U.S. can employ? Not generally, and then I'll get to women and girls specifically, being able to work now to prepare for what we know is inevitable is really critical. It's very hard to do that. It's much easier to respond, but preparedness, we know, makes a huge difference. When the U.S. can help other health systems through ministries of health, in particular, and this is work, for example, CDC does, that can have long-lasting ramifications. That's what we want. We want a system that it can immediately respond to a potential outbreak. So that's critical work, and I know that's be something you'll discuss later today. Just to add to what Sheba said around what happened, we don't always think about women's needs in these contexts, and for all the reasons she mentioned, women are particularly vulnerable. The other thing that tends to happen is if a health system isn't robust, the very basic services that women need, whether it's a skilled birth attendant, delivering in a hospital, getting basic maternal health needs met, family planning services get disrupted and resources and attention get diverted. And that happens every single time. The more robust a system is in the beginning, the less likely that's going to happen. So it's a win-win, but one that definitely needs more attention.
Thank you very much. I yield back.
Thank you. Mr. Pence, you are now recognized. I'm sorry?
Thank you, Madam Chair. To all the witnesses for being here today, thank you very much on such important issues. Ms. Boss, I found your testimony to be particularly interesting. First, I'd like to thank you for World Vision's work in promoting the sanctity of life and combating maternal and infant mortality in developing countries. I agree that abortion is not health care, and that vulnerable women seeking true comprehensive care around the world deserve better than abortion-centric facilities. In my home state of Indiana, working towards lowering the infant mortality rate is a priority for Hoosiers. In fact, in 2018, Indiana's infant mortality rate showed the biggest decrease in 6 years. While this is encouraging progress, we must remain vigilant. Similar to World Vision's time and targeted counseling home visiting program, Indiana recently launched OB Navigator in 20 of the 92 counties to support women in high-risk communities, 6 of which are in my communities. The goal of this program is to improve prenatal and pregnancy care for vulnerable Hoosiers. Ms. Boss, as we continue to expand this program, what advice would you give to new home visiting programs? And are there key challenges to new home visiting programs that must be overcome to reach the most vulnerable populations in Indiana?
Well, kudos to Indiana for their leadership in this space, and I say that carefully as a native Michigander. I do think there are challenges in doing home visits. Our programs, we work with volunteers. As others have noted, these volunteers are mostly women, these health workers. So they're taking time away from their own homes, their own families, potentially businesses, livelihoods. I think that's one of the biggest barriers. I don't know how Indiana is addressing that issue, but as we look at how we do programs, how do you start to integrate those health volunteers into the formal health system, maybe get them a stipend, is something we're starting to look at. There needs to be some incentive at times for these health volunteers to continue doing this work. I would say the other barrier oftentimes is just having the right information at the right time. And really, that's where we're trying to use mobile phones more often. Our timed and targeted counseling messages are often now coming to women and to the health volunteers just right through a mobile phone. You've all probably heard about, women might not have access to a health facility that's nearby, but they'll have access to a mobile phone. So using technology is increasingly critical, and I know in the domestic sphere, that's been something that the U.S. government has been looking at as well. How do we better leverage technology?
Thank you. Thanks again for all that all of you do. Madam Chair, I yield back.
Mr. Cicilline, you're now recognized for 5 minutes.
Thank you, Madam Chair, and thank you to our witnesses for your important testimony. Dr. Cates, I want to start with you. There was some suggestion made by some of my friends on the other side of the dais that access to abortion services cannot be part of a woman's health care. Would you like to respond to that assertion?
Well, I'm here as an expert on what the U.S. government does and the policies, so I'm not going to take a position either way. But I will, just to reiterate what I said before, that the services that the U.S. government does support, voluntary family planning, HIV treatment and prevention, a range of reproductive health services, and many more, to the extent that these may be disrupted by a policy. I don't think the intention of the policy is to disrupt them, but there's evidence that that could be happening. It's cause for concern.
Thank you. And despite the expansion of access to prevention and treatment for HIV, TB, and malaria, these epidemics continue to threaten the health of women and girls worldwide. Maternal health services have been identified as a point of entry for improving access to prevention and treatment of HIV, TB, and malaria in women. And again, Dr. Cates, in what ways are we tailoring interventions, if we are, to protect women, particularly those of reproductive age?
So I think that's a fundamental thing, that we have to understand where women are going to get their health care, what kinds of services they need. I'm a parent. You want to do what's best for your kid always. And so reaching women where they're going for maternal health care and for their kids is a critical approach. PEPFAR is doing that more and more. I know that the USAID's MCH and maternal and child health and family planning programs over the last few years have really started to integrate much more their work so that they're trying to meet women together. But there's a lot more that could be done. So there's real opportunity for the U.S. to step back and understand where it's working, which countries in terms of overlap with the programs, and where they could meet women in most in need. What sites is the U.S. government working in?
Thank you. And we know that LGBTI persons face higher levels of stigma and discrimination in their communities, including when seeking healthcare options. However, when LGBTI persons also require a unique set of services, including HIV prevention and treatment, comprehensive sexual education, and family planning. And we know that as a result of this, their clinics have developed programs specifically designed for the LGBTI population, and they're seen as trusted sites for other medical providers to refer LGBTI patients. And my question is, given the global gag rule's expansion to all of U.S. global health assistance, including PEPFAR, these same clinics may have been forced to close or, if gagged, have had to scale back their integrated and comprehensive healthcare services. And so, Dr. Cates, what has been your assessment of the impact of the global gag rule on LGBTI populations who require this kind of integrated and comprehensive range of services?
So as you mentioned, there's been a lot of effort by the U.S. government through PEPFAR, through USAID, to enhance services for LGBTI populations because those populations are often criminalized, face violence, face stigma in their countries, and not reaching them has tremendous impacts on their health. And in fact, in the context of HIV, key populations, including men who have sex with men and transgender women, make up more than half of new HIV infections. So ending the epidemic, ending AIDS is not going to happen unless key populations are reached. I think in the context of this expanded Mexico City policy, the studies that have been done so far suggest that there have been service disruptions and clinics have closed in some places. Many times with populations like the LGBTI community, there are very few providers to begin with. And the U.S. has often worked with them to bring them on and help build their capacity. To the extent that those providers choose not to be a partner of the U.S. government, choose to stop offering some services that may be legal in their country because they don't understand a policy, that could really affect the availability of services to the most vulnerable. And I think that's something the U.S. government should pay very close attention to.
Thank you. In my view, reproductive rights are human rights, and without full access to reproductive health care, including information about comprehensive sexuality education, contraception, and access to abortion, women and girls are undermined in their ability to make decisions about their bodies and health. Mr. Mulumba, is there value in the United States reporting on reproductive rights in countries? We've lost that reporting and really understanding what the condition has been and the impact for the last 2 to 3 years. By cutting these sections out of the State Department reports, are we losing the ability to kind of understand the full impact of these decisions?
Thank you so much for the great question. I think historically human rights have been divided, and much of the time we focus on civil political rights and forget about socioeconomic rights. And the nature of reproductive rights is that they are cross-cutting. Unfortunately, we only look at them as socioeconomic rights. At the national level, there is a lot of focus on civil political rights and non-socioeconomic rights. So it would really help if United States focuses on comprehensive reporting on human rights. Because our countries, while sometimes don't appear to respect human rights, the human rights reporting is used as a tool, as mobilization of shame for the countries and compliance, and it would therefore be a missed opportunity if United States does not require the reporting on sexual reproductive health rights.
Thank you very much. I yield back, Madam Chair.
Thank you. Mr. Guest.
Thank you, Mr. Chairman. Members of our panel, as we meet today to discuss challenges in global health, I believe it's important that we address the challenges faced by the most vulnerable of our society, by our children, both born and unborn. The World Health Organization reported in their last report that between 2010 and 2014, that over 55 million abortions were performed each year across our globe. That equates to over 150,000 abortions each day, 100 abortions each minute. During the 5 minutes that I have to address this panel, over 500 children will lose their lives because of abortion. I believe that all life is precious. I believe it is a gift from our Heavenly Father, and I believe that our founding fathers held that same belief. We find that in our earliest documents, the Declaration of Independence, where our founding fathers held that we hold these truths to be self-evident, that all men are created equal, that they are endowed by their Creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. We have seen great medical advances and medical treatments. Last night, that was on display when President Trump recognized a young lady who was born after 21 weeks and 6 days. To our friends at World Vision, I want to thank them and their 220,000 community health workers and volunteers, and I want to thank you for your belief that life begins at inception. World Vision, along with the other organizations and USAID, have helped save the lives of more than 9 million children and over 340,000 women over the last 10 years. Ms. Biles, I agree with the statement that you gave and the conclusion of your written statement. Improving health for the world's most vulnerable people is not only a moral imperative, but also a pragmatic investment for peace, security, and worldwide economic growth. Ms. Biles, my question to you is, what role do you see telemedicine playing in improving the health of women and children across our globe?
Thank you for that question, Congressman. As I mentioned to Congressman Pence as well, I do think technology presents some great opportunities for how we do healthcare in the developing world. Having done domestic health work when I was here working as a staff member in the House, we saw the opportunities that telemedicine presented in rural areas and bringing resources to people. I do think there are some challenges with that in the developing world, but challenges we're trying to overcome. If there's not electricity, if you can't, purchase the right kind of equipment, that does present some barriers. That's why we tend to lean right now toward more kind of mobile phone technology. But I do think there are unique opportunities for new partnerships and how we better use telemedicine, especially because there's such a lack of physicians and really high-quality trained health professionals. We need to start looking at those other new innovations.
Thank you. Thank you, Mr. Chairman. I yield back.
Thank you very much. Ms. Titus.
Thank you, Mr. Chairman. We've heard a lot today about how the global gag rule has a negative impact on women generally. We've heard a lot of pontificating about the sanctity of life from those who often vote to cut critical services for children in vulnerable communities. We also heard a little bit about some of the specifically more vulnerable populations among women, including LGBTI. I'd like to now look at two other groups that we haven't talked about as much, and that would be female sex workers, who are certainly vulnerable, and also women with disabilities. Sex workers are a population that faces a significant amount of stigma in their communities. This often extends to healthcare settings, discrimination, and interaction with healthcare providers. In particular, they have unique family planning, contraceptive, maternal health, and abortion needs that are related to their work, and they often report limited access to information about these services. Data also show that female sex workers face a disproportionately high risk of acquiring HIV, 21 times higher than the general population. Given this clear need for services, treatment among female sex workers, some healthcare services have created specific outreach programs to build entrusted relationships and provide stigma-free care. Unfortunately, we hear that these programs are being forced to scale back or even shut down due to the global gag rule. Also, we know the other vulnerable population I would ask you to address is that women and girls with disabilities. They too are at a higher risk of HIV infection, as well as stigma and discrimination, and also difficulty in just getting access to the health care services that they need. Starting with you, Dr. Cates, would you address some of the problems and how we can do better serving those two communities?
Certainly, I'll focus on the first that you mentioned, female sex workers, because as you mentioned, they are at much higher risk of HIV, and other health challenges are often overlooked, criminalized, not given access to services. Within the U.S. government's purview, PEPFAR is the program that has probably moved the furthest on this and makes female sex workers and male sex workers a priority key population that it focuses on. One of the challenges, though, is working in environments where they're not able to get services at all. So in some cases, PEPFAR has helped to create those services, but others, it is working with challenging local laws and cultural beliefs. One thing PEPFAR is doing now and is planning to scale up is PrEP, pre-exposure prophylaxis, which is antiretroviral medication one takes before exposure to HIV that prevents HIV acquisition by close to 99%. This is a tremendous intervention, and PEPFAR is going to be scaling that up, but that still the uptake is very, very low. So I would just think looking at PEPFAR's ability to do more in the countries in which it works, as well as USAID's other programs that haven't had as much of an emphasis on reaching female sex workers.
Thank you for the question, and I think one thing that it highlights is that there are unique challenges that are faced by marginalized parts of populations. So just to sort of bring it up to a level of generalization, and to note that, the importance of protection activities in the context of humanitarian emergencies, sometimes those may be specific to women and girls generally, sometimes those may be specific to particularly discriminated against groups within society. I think your question also raises, again, the importance of ensuring that women and girls, and in fact all members of the population, have access to the tools and education they need to make informed decisions and voluntary decisions about their own family planning needs. In certain cases, there is enormous stigma due to social norms in certain communities around things like even reporting. So we've talked a bit today about the statistics around gender-based violence as an example. But because of stigma, we actually think that those statistics are probably underreported, right? So that as high as they sound, they're probably actually worse than what we know. And I think in terms of female sex workers, the stigma is only heightened. And certainly, I think in terms of having, enabling access by disabled people, whether girls or otherwise, in humanitarian emergencies is only more challenged. We've talked a lot about the degraded health systems generally in the context of humanitarian emergencies, and the difficulty around access issues that, again, especially marginalized members of societies face.
Thank you. Very quickly, I think one of the immediate impacts when programs are cut to special groups like sex workers and women with disabilities, the argument has been that you will find alternatives in other areas, but these groups receive treatment as a result of trust. So trust is created with providers over some time. So once you have immediate cuts, they may not be able to receive services because of the lost relationships that they have had with institutions that have lost funds. And it's really a serious problem with the global gag rule.
Just really quickly, recognizing the time, disability inclusion is a huge priority for us in our programs. It's something we factor into all of our programming, making sure, identifying the barriers, and really focusing on that. So it's definitely a priority in our work.
If you have some specific information on that, could you send it to me or any of the federal programs, Ms. Cates?
Yeah, I just want to add one thing. While clearly there are NGOs that do that work, it has not been something, it's a gap in USG programs and policies. There's not an emphasis on this in the global health programs that are supported.
That's what I feared. Thank you, Mr. Chairman.
Thank you, Ms. Titus. Mr. Keating.
Thank you, Mr. Chairman. First off, I just want to reaffirm my support as original co-sponsor for Representative Lowy's bill, the Global HER Act, as well as work as a co-sponsor in International Violence Against Women Act, and with the recent resolution we had showing our concern as a Congress with treatment of children and the violence in that regard. The way women are treated, the way children are treated, I'm reminded when you're on a plane sometimes and they warn you, the flight attendant will warn you, if the pressure goes, the mask will come down. Put your mask on first before helping others. And I think as we talk about protecting children, it's just inexorably connected to protecting women and the mothers and their family members in that regard. So this has been an important hearing in bringing that together, and it's a terribly important issue. I want to hit something that probably hasn't been discussed as something that could interrupt your program, besides the fact that our policy is an on-again, off-again policy, which really hurts, I think, the ability of you to do your jobs. But I want to touch base on how climate change can affect and disrupt your programs as well. You have areas of Africa, sub-Sahara, where there's really this problem with children is the greatest. And I don't think it's coincidental that that's an area struck by climate change and the challenges that surround that. So if you could talk about how sometimes climate change, not just in the long-term effects of this, that result in famine, drought, water supply, other things, but also what happens when there's natural disasters that occur and how that disrupts the program and how that leaves women and children more vulnerable. I guess, Ms. Crocker, that's something that you could speak to.
Thank you. And I mean, for sure, the impact of climate change and the climate crisis is impacting our own programming, but I think more importantly, and as your question alludes to, really impacting countries and communities around the world, including those that aren't necessarily used to dealing with those kinds of disasters. And so we saw, for example, last spring with the double cyclones in Mozambique hitting a country that had just not seen that type of disaster before. And the implications that has in terms of the ability of the local communities and the local governments to muster the right kind of response. And also the resilience of those communities. CARE sees in our work all over the world the impacts of climate change, the things you mentioned, drought, famine, other things, and we work with communities both to help them respond in times of crisis, when sometimes you might be in a longer-term development posture, but then there is a rapid onset crisis of some kind, but also, importantly, to help build and create the conditions under which communities themselves can build their own resilience. But of course, when countries, including here and communities here in the United States, are facing disasters of types that they've never seen before, that is more challenging. The confluence of impacts of the climate crisis and the protracted conflicts and crises that we're seeing around the globe are also not something to forget, right? So we both are seeing an enormous wave of displacement due to conflict around the world, but we are also increasingly seeing displacement due to climate. And I think what we'll all need to be watching for is how also those two things come together.
Yeah, and I honestly believe that, tying my two comments together, that it's so important, whether it's a short-run emergency or whether it's a longer-run climate change effect, that women have to be more a party to dealing with the programs around that. There shouldn't be this divide. Well, we're going to take care of this here, but then you're doing all your work where it is there. So I hope there's more of an integration into that in the future. I think it's necessary. And I don't know if anyone else wanted to briefly comment.
If I could just add briefly, just to note that in all of our responses as CARE, we do a rapid gender assessment to understand the gendered implications of a disaster, whether it's man-made or natural disaster. And I think you're exactly right, and it alludes to some of the things that we've been discussing earlier around the importance of addressing the particular needs of women and girls, protection needs and health-related needs from the outset of a disaster all the way through.
And if women and those mothers aren't involved in that planning, it could get left out. In fact, it does. So I yield back, and thank you for all the work you're doing.
Okay, thank you. I understand that Mr. Smith would like a second opportunity to ask questions. So,
thank you, Mr. Chairman.
Mr. Smith, you're recognized for 5 minutes.
Mr. Chairman, thank you very much for that courtesy. Let me just, I learned of the forced abortion policy in the PRC in China in 1983. In 1984, offered an amendment saying that any organization that supports it should no longer receive U.S. funding. Jack Kemp and Senator Kasten added it to the appropriations bill, and we've had Kemp Kasten ever since. Kemp Kasten says voluntary yes, involuntary no. China is the most brutal example of coercion. I've chaired many hearings with women who had been forcibly aborted, who told their stories, and the degradation, the impact on their bodies, and especially on their minds as the government coerced them to kill their babies. Unwed mothers in China have to abort. I mean, in this country, thankfully, we put our arms around unwed mothers and try to protect them and help them through. All of UNFPA's money that is denied by the U.S. government goes to family planning and maternal health. So it's a one-for-one, dollar for dollar. We do support that. I had a number of hearings on the missing girls, both in China and in India, and I had one woman, an expert, Mira Wiesenstahl, who wrote a book called, and I read it, and I encourage all to read it, Unnatural Selection, Choosing Boys Over Girls, and the Consequences of a World Full of Men. She said, and quote from the book, by August of 1969, when the National Institute of Child Health and Human Development and the Population Council convened another workshop on population control, sex selection had become a pet scheme. She goes on to say sex selection, moreover, had the added advantage of reducing the number of potential mothers. Kill the girl child in the womb, and she'll never be a mother, perhaps in her 20s or 30s, or even before. If reliable sex determination technology could be made available to a mass market, there was a rough consensus that sex selection abortion would be an effective, uncontroversial, and ethical way of reducing the global population. Fewer women, fewer mothers, fewer future children. At the conference, she goes on to say, one abortion zealot, Christopher Tizzi, co-presented sex selection abortion as one of the 12 new strategies representing the future of global birth control. We are missing, and my good friend Ms. Wagner mentioned it in her comments, well over 100 million women who should be here, but for the reason of their gender, the fact that they were a girl child in utero, was killed by abortion. My question is, do any of you support sex selection abortion? Have you seen the impact it has had on India? And in China, it has had an impact on human trafficking. For years, I tried to get the TIP office, the Trafficking Persons Office, to recognize that when women are killed in utero because they're girls, the girl child, that creates a huge space for the human traffickers to fill a void because men can't find women to marry, and that is a huge problem in the People's Republic of China as a direct result of the missing daughters. There's also the suicide issue. China is one of the countries, I think it's the only one, where the rate of suicide among females far outnumbers the rate of men. The coercion clearly has something to do with it. The UNFPA has supported the Chinese program. We have asked them to leave, and yet you know as well as I that they have to comport with all of the China's laws and policies and regulations to do business there. Marie Stopes had to do that when they were there. They probably are still there. I'm not sure of that. But they were denied money under Kemp Kasten. And certainly the UNFPA has to comport with those laws, which makes them part of that coercive machinery. Remember, no unwed mothers, one child, now two child per couple policy. For a long time, all brothers and sisters were illegal. So I would ask you, do you support sex selection abortion? And are you concerned about this huge, we have two girls, two boys in my family, and my wife and I. When we found out it was a baby girl, we celebrated. Couldn't have been happier. It's a girl. That phrase is one of the most dangerous phrases in some parts of the world. And 20 countries, like I said, have these disparities of male to female. On that question, and do you believe that China's program is coercive? Ms. Crocker?
Well, I would say to start off that CARE is, of course, vehemently opposed to sex-selective abortion, as well as any form of systemic gender discrimination. And sex-selective abortion, as you know, is usually premised on harmful gender norms and stereotypes that stem from a belief that a male has greater value than a female, a belief actually that CARE seeks to address in our programming. We believe that the most effective way to address harmful gender norms that devalue women and girls is to address the root causes of gender inequality. CARE works with local partners and communities around the world to engage not only women and girls, but also men and boys as well, to improve education, to improve health, to improve economic opportunities for women, and to create lasting change that benefits everyone in a community.
My organization is not an implementer, and we don't take positions, but I would just echo what Sheba said, that the overall gender discrimination and conditions that create such hardship for women and girls in societies is something that the U.S. does work to combat and address, but clearly there are significant challenges, and it's a very serious issue.
I'm going to have to cut it now because your time has elapsed, Mr. Smith. Ms. Omar.
Thank you, Chairman, for having this important conversation. Thank you all for being here. My apologies if my line of questioning has already been dealt with in committee. I really think that there is a pressing global challenge of child marriage. Currently, we have 650 million women who are alive who've been married before their 18th birthday, and 12 million girls who are at risk of becoming child brides each year. We know that issues are compounded, that issue is compounded by poverty, safety, and security. Many countries have implemented laws to outlaw child marriage, but there are countries like the United States that allow with consent for some states to have young girls get married before they are 18. And so I'm wondering if, Jennifer, if you have any thoughts to how we can create societal shift in recognizing how harmful this practice is, and what would it take beyond the implementation of laws for us to be able to outlaw this global crisis?
Thank you for the question. Clearly a really critical global issue. One of the biggest ramifications of child marriage is the physical and emotional harm for young girls. And that in and of itself goes against what the U.S. government is trying to do to enhance the lives and livelihoods of young people and women in countries in which it works. I think what the U.S. has done, and probably would continue to have the biggest impact, is addressing the root causes and the structural challenges that create the conditions that would lead to young women against their will or without any say being married at young ages and ultimately giving birth at very young ages. And that is more access to education, more access to income-generating opportunities, things that will keep them healthy and also allow them to have more voice and opportunity. The U.S. government does work in this area, but clearly there's a lot more to do. Thanks.
Do any of you want to chime in?
I'm happy to just add briefly from World Vision's perspective. Preventing child marriage is a complex issue. We need to work with parents, we need to work with schools, we need to work with faith leaders or traditional leaders who are performing the marriages. You're correct in that the enforcement piece is critical. In so many of these countries, laws are on the books, but we still see girls getting married ages 12, 13, 14. So it's a critical issue. I agree with Jen. The U.S. government is doing some work in this space. I really have appreciated, especially PEPFAR through the DREAMS program focused on adolescent girls, really helping girls feel empowered and feel like they can say no to early marriage.
Yeah.
Sorry, if I could just add, to bring it back to the context of humanitarian emergency also, which we've been discussing a lot, and just to note that child early and forced marriage also often increases during emergencies. It's a negative coping mechanism sometimes that families need to resort to or feel that they need to resort to in the context of emergencies. And I have flagged several times today the Safe from the Start Act, which is a bipartisan bill before Congress, and one of the things that the Safe from the Start Act would seek to address is child and early forced marriage in the context of emergencies.
Mm-hmm.
So on that point, I think in Uganda, where I come from, it's one of the biggest problems. So having children is such a huge problem, but it moves beyond the law to changing the societal norms. Mm-hmm. And one of the big challenges we've seen is that these are not arranged as marriages, but a young girl comes when she's pregnant and she's still in the same society and the side of the offenders, begin to negotiate with the other side. So we have systems where even safe spaces are not provided. We are challenging the government of Uganda for having no single safe space for girls that have been offended in situations like this. So it will take laws, but it will also take engagement within the communities, but also challenging the government.
Yeah, I mean, having children is a huge problem. I've found it to be quite alarming in the number of countries that have policies on the books that have increased the legal age for young women to get married, but still have this problem persist because it is such a societal norm. I was even shocked as someone who comes from the same part of the world as you come from to find that even in my own state of Minnesota, that you don't legally have to be 18 to be able to get married. And it is such a tragedy that there are so many young women's opportunities for education, for a stable life that doesn't get to be advanced because they are sometimes forced to become mothers and care for others. So I appreciate you all for the work that your organizations do, and to many of my colleagues who deeply care about ending this crisis. Thank you.
Well, thank you. Thank you, Ms. Omar. I also want to thank our witnesses and the members who participated in this very important and interesting hearing. I want to thank the audience for being here today and showing their support. And with that, the hearing is adjourned. Okay, Chris, anytime.